Without further ado, we begin with our main session, presentation from Dr. Linda. But before that, kindly Panitia to display her short CV of Dr. Nurlinda Hambun. Okay, what a great trace Dr. Linda have. So she's an expert in this field on polymorphism of vitamin D receptor. Without further ado, please, Dr. Linda, the time is yours.
Terima kasih. Thanks to the moderator for the time, Dr. Erni. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. First of all, I would like to thank Allah for this healthy and opportunity, and also I would like to thank of the ICoBTD committee for inviting me in this event. Okay, on this opportunity, I would like to show you the result of my research with the title Vitamin D receptor gene polymorphism as a risk factor for chronic periodontitis. Next. Chronic periodontitis is inflammation of the periodontal tissue is characterized by the apical migration of the junctional epithelium with loss of attachment and destruction of the alveolar bone crest. The multifactor disease is caused by an imbalance of periodontal pathogen host immunity, systemic and local factor. It is still a health problem in the world, both in developed and developing countries. Periodontal prevalence, case of chronic periodontitis in the world is still very high, such as data from WHO, around 40 until 70% from various countries. Data from America, 35 in America and 56% in Canada. In Indonesia, around more 80%. Next. Back to. Yes. Causes are divided into 3 categories. That is main cause, such as bacterial plaque and scleroderma. Host factor such as genetic, age, sex, nutrition, smoking, stress, and diabetes mellitus disease. And secondary factor such as carriers, restoration, prosthetic, and chronicity. An epidemiological study concluded host defense from birth is essential factor in determining the occurrence of periodontitis. Various genetic factors mediate this variation in host response. Genetic polymorphism causes change in protein or its expression, so that change is innate and adaptive, and then to susceptibility and disease severity. Next, vitamin D receptor, the next I will call VDR, is nucleate receptor that act as transcriptional regulator and occur in various cell types. Function in bone and mineral metabolism, regulation of immune response, and ability to resist infection. VDR polymorphism can play a role in the pathogenesis of disease related to bone tissue and invited immune response. Shown in the screen of the VDR gene is located on chromosome 12 key and has 14 exons. Next. The result. Next. The result of research on the relation between VDR gene polymorphism and chronic periodontitis in various populations are very few and different. Indonesia, until now, there is no data on this matter. Based on the days, we did a risk VDR gene polymorphism as a risk factor for chronic periodontitis. Next. Chronic periodontitis, operational definition, chronic periodontitis determined by pocket depth, that is probing pocket deep. Next, I will call PPD. Is the distance from the pre-gingival margin to the base of the pocket, loss of tissue attachment, that is clinical attachment loss, and the next I will call clinical attachment loss. Is the distance of the cemento enamel junction to the base of the pocket. The highest score was taken from the 6 to surface examined. Operational definition. VDR gene polymorphism. Change in the nucleotide base arrangement in the VDR gene were determined based on the rexisine endonuclease TAC1 at exon 9 and the VDR gene examined by rexisine fragment length polymorphism, RVLP, PCR, and direct sequencing method. The assessment criteria are: if the result of the RVLP PCR examination on a blood sample, the following genotypes are found: double capital T at around 1,000 base pair, combined capital and small t around 900, 400, and 1,000 base pair, and double small t around 900 and 400 base pair. Subject criteria: age subject 25 until 60 years old, not suffering from DM, TB, hepatitis, or HIV, not smoking, not taking anti-inflammatory drugs, not pregnant, breastfeeding, taking birth control injection, and mass cooperative. Research procedure. The first of research procedure is a sign informed consent and a clinical examination and blood sampling. Next, DNA extraction, RVLP PCR. Framers is forward like this and reverse like this. Electrophoresis, result reading, and sequencing shape. Sequencing result were analyzed using BLAST, basic locus alignment search tool, based on the NCDA database. Next. research result, characteristic of research subject, based on the table, in all variables, the value are almost the sample in both groups. Specifically for VVD and call variables, they were not measured in the control group because they didn't suffer from chronic periodontitis. Next. That is better about VDR gene polymorphism. One of the result of the RPLV PCR examination of the case group and control group. The pictures show they are double capital P on 1398 base pair, around 1000 base pair. And this is mean normal subject, and combined capital and small t, there are on 9, 4, 6, and 4, 5, 2 base pair, and 1000, 1, 3, 9, 8 base pair. This is mean heterozygote polymorphism of the VDR gene. And double small t on 9, 4, 6, and 4, 5, 2 base pair. This is means homozygote polymorphism of VDR gene. Compare this with the control group, where there are also a double capital on around 1000 base pair, and there is combined capital and small t on around 900 and 400 base pair and 1000 base pair. As we can see, as we can see, genotype variation like this double capital T, combine capital and small t, double small t of the VDR gene were found in the both group. This means VDR gene polymorphism have been found in a population of chronic periodontitis patients. Detective 3 genotype variants, there might be an influence of a genetic factor on the incidence of chronic periodontitis. Next. The relation between the VDR gene phenotype and the incidence of chronic periodontitis. So in the table, in the heterozygote capital T genotype in case group, there were 70 subjects or 86.4%, and the heterozygote combined capital T and small t, and homozygote small t, there are 11 subjects or 13.6%. While the control group for the heterozygote capital T genotype as many as 80 subjects or 98.8%, and heterozygote combined capital and small t only one subject or 1.2%. This is study use p-value 0.005. A statistical test result report significant association between VDR gene polymorphism and chronic periodontitis. Further test calculate odds ratio and obtain 12.5. This is means the sample with the VDR gene polymorphism are 12.5 times more likely to suffer from chronic periodontitis than those who do not. Nice. Next. This graph presents the same data as the previous table. And next. Comparison between VDR gene genotype in chronic periodontitis patient based on age, oral hygiene index score, probing pocket depth, and clinical attachment parameter. Based on the table, examination of probing pocket depth and clinical attachment loss explain that the VDR polymorphism has a significant relationship with the incidence of chronic periodontitis. For probing pocket depth have 0.006 p-value, and clinical attachment log have 0.001 p-value. This graph presents the same data as a previous graph. And the next. Polymorphism begins as a mutation that occurs due to DNA damage, so that the frequency grow in the population, and then few polymorphism. The difference allele frequency between ethnic group tends to be due to the evolutionary process and the genetic characteristic of the population. Allele frequency across ethnic group correlate with various disease incidence or phenotype in that group. Some research result of so similar next. Yes, some research result that show similar to the result of this study, such as Brett report significant association between VDR gene polymorphism in chronic periodontitis patient in Caucasian race. Tashi report that obtaining odds ratio 2.3 in Japanese population. Nibali report obtain odds ratio 15.24 in chronic periodontitis and aggressive patient in Caucasian race. The Brighto report the genotype and haplotype of VDR gene polymorphism had odds ratio 2.41 and 4.32 with periodontal disease, and Borges found an odds ratio of 4.57 between VDR and chronic periodontitis in a Brazilian population. Next. Here some research result that show the difference research result, such as Yoshihara report in the Japanese population. They didn't find any significant difference in the distribution of the BSM1 VDR between the case and the control group. Another study in the Chinese population report by San et al. Also found no significant association, and Tashi report that the association between VDR gene polymorphism and the incidence of chronic periodontitis was not significant. The mechanism of action of the VDR gene in the immune system. The mechanism of resistant gene microba initiated by toll-like receptor activation. toll-like receptor activation 1 and toll-like receptor 2 activation in monocyte cause VDR expression and 1-alpha vitamin D hydroxylase, such as CYP27B1 gene. And the product of the CYP27B gene, B1 gene, altering provitamin D become vitamin D active. And vitamin D dehydroxylase, vitamin D3 together with VDR cause the calcium absorption, control bone remodeling, suppress parathyroid hormone function, and calcium reabsorption. So that plays a role in the formation and regulation of bone homeostasis through in action on osteoblast and chondrocyte, as well as through bone metabolism. If one of these components is disturbed, then the skeletal balance does not take place properly. Next. Dehydroxyvitamin vitamin D3 together with VDR can induce catalysidin peptide active, and so that kills microbe directly, including bacteria that cause periodontitis, for example, Purpurina gingivalis, Candida, Fusobacterium nucleatum. And when polymorphism occurs, vesicle does not do well. Next. The role of VDR in periodontal tissue health through its function in bone metabolism and innate immunity. Variation in the VDR allele are responsible for the variation in bone mineral density. VDR polymorphism cause the concentration of calcium and phosphate in blood is disturbed, so that decrease body bone mineral density, including maxilla and mandible. Decrease jawbone bone mineral density cause alveolar porosity increase, change in trabecular pattern, and rate of bone resorption after invasion of periodontal pathogenic bacteria. Periodontal infection will cause release of pro-inflammatory cytokine and will cause accelerated systemic bone resorption. From the explanation above, it's appeared that polymorphism in the VDR gene can have an influence on decreased immune function and bone resorption. It's assumption that the combined capital and small t or double small t genotype detected in VDR gene in this study affect to the stabilities of messenger RNA in osteoblast cell composition, so that decrease osteoblast function and increase osteoclast function. So it happen decrease bone mineral density in the small t allele or double small t genotype, and it finally happen intensive alveolar trabecular bone reception. Presence of bacterial infection and decreased immunity can cause periodontal tissue damage getting worse. Is evident in the result of our study where probing pocket depth and clinical attachment loss value were high in patients with chronic periodontitis who had this genotype. As shown in the figure, several positions of the VDR gene polymorphism have been detected. Analysis of VDR gene polymorphism with sequencing technique. In this study, the genotype double small t had higher periodontal tissue damage then the mean probing pocket depth genotype combined capital and small t, and the mean genotype double capital t 3.52 millimeter. The result of the sequencing examination in this study found that there was a change in the nucleotide-based sequence in chronic periodontitis patient who had the genotype double small t. A sequence change from adenine guanine T mean cytosine guanine adenine to adenine guanine cytosine cytosine guanine adenine at codon position 352 of the VDR gene. A change in the nucleotide substitution variation of T to C, T mean to cytosine, in this case GTC to GCC, with the conversion of the asam amino valine to alanine. This asam amino acid chain are likely to affect the expression level of the VDR gene, so that the level of protein translation or cause change in the stability and translation of RNA. This is true. Patients with this allele are susceptibility to decreased bone density or a weakened immune system. This is seen in the phenotypic chronic periodontitis genotype double small t with probing pocket depth value around 8 millimeter, far above the average probing pocket depth. Further research is needed to analyze this pathomechanism. Conclusion, VDR gene polymorphism were found in the patient with chronic periodontitis. VDR gene polymorphism is a risk factor for chronic periodontitis. VDR gene polymorphism affect the phenotype of chronic periodontitis. And the last, it was found that there was a genetic variation in patients with chronic periodontitis, that is the shift in the amino acid valine to alanine. Suggestion, further research is needed by looking at haplotype with several polymorphism in other parts of the VDR gene or other gene that might play a role in incident of chronic periodontitis. Further research regarding the VDR gene polymorphism with a more significant number of control sample, good matching, and control of other confounding factor. And further research is needed on the polymorphism of the VDR gene that develop interaction with other risk factor. Thank you so much for your interest and attention. Wassalamualaikum warahmatullahi wabarakatuh. Have a good day.
Thank you, Dr. Linda. What an excellent presentation. Now I understand a little bit about the PDR. Ladies and gentlemen, distinguished participant, if you have any question, you can either raise your hand and talk directly to our speaker, or you can write down your question into the chat column below you. I saw that there is one raised hand in here. Who's sorry? Let me see who's. Okay. Kindly, participant, if you have any question, you can go directly to Dr. Linda. To Jet Lolong, Doctor, organizer, please let Dr. Jet to open. Is it his or her? Her microphone. Yes, Dr. Jet. Silakan. Hello, Dr. Jet. Can you hear me? Dr. Yaya, can you hear me?
Yes, Doc, I can hear you, Doc.
Okay. I saw that Dr. Jet has raised her hand. If you want to ask or any opinion, okay. Otherwise, while we waiting question from our participant, I would like to ask, what is Dr. Linda actually the difference between mutation and polymorphism? Is it mechanistically different or just terminology different?
Thank you, Dr. Repnik. This is an interesting question because many students ask the difference between mutation and polymorphism. Mutation of polymorphism have similarity because they both experience an error in arrangement of nucleotide base. The difference is in the prevalence of the population. Mutation have a prevalence of less than 1% in the population, and polymorphism have a prevalence of more than 1% in the population. All polymorphism start with mutation, but a few years later, the mutation will develop into polymorphism. Maybe one of the case is the marriage between mutation subjects.
Okay. So it's kind a community identity, genetic community identity. So it can identify one genetic behavior in one community, yeah, doctor, not in individual.
Yes.
Okay, not individually.
No.
Perfect. The same question actually asked by Dr. Irfan. That's why we didn't see the difference actually. What the difference between mutation and the polymorphism? I hope it's answer your question, Dr. Irfan. And the next question came from Dr. Acing Habibi. Yeah, Dr. Acing said, thank you for the nice presentation, Doc. And he also asked, is there any literature or studies mention that specific ethnic in Indonesia susceptible to chronic periodontitis based on PDR gene examination? So he asked whether there is any other research, the same research with you about gene polymorphism in Indonesia, specifically as far as you know.
My research in social population.
So yeah, so there is no other research in Indonesia, either in Jawa or Sumatera.
I don't know because my research very long time ago.
Okay. So when
maybe yes.
Yeah, when Dr. Linda performed her research, this might be the first research about VDR gene polymorphism associated with periodontitis. But when this research done?
A long time ago.
Is it 10 years ago?
Yes. Maybe.
Yeah, so it was 10 years ago. I believe there will be one or two the same topic research. And also Dr. Asing asks, in the clinical setting, Doc, can we measure VDR gene relating to the chronic periodontitis? Can we do the measurement of gene polymorphism in clinical setting?
Oh, I actually exam for PCR and FLV restriction length FLV polymorphism.
So yeah, so it is applicable, Doc, yeah? So we can use it in the
Yes.
clinical setting. Okay, is there any other question, please? Okay. Is there any other questions? Okay, Dr. Linda. So I have heard that the gene therapy is on the way to clinic at this moment. So do you think we can use this VDR receptor as a marker to, to identify or to alternatively treat periodontitis?
Thank you. And if genetic testing was achieved, maybe genetic variation examined can become a routine check-up procedure. So that treatment and care for a patient is optimal. But no, preventive medicine has begun to develop gene therapy treatment against mutant or abnormal genes.
Okay.
Yes.
So it's on the way. So in future, hopefully we can use this to
Yes.
treat periodontitis.
Yes, I hope this.
Okay. While we're waiting for other question, we still have around, I think, 10 minutes. If you don't mind, Dr. Linda, I would like to ask, if I saw your VDR gene polymorphism feature, like we displayed here,
Okay.
in the control group, there is one sample that demonstrated a different behavior compared the other control groups. So this sample demonstrated capital T and double small t and combined small n big T. Yeah. Is there any reason though?
Polymorphism can be had by everyone.
Yeah.
A person may be phenotypically or clinically invisible, meaning that the subject may appear normal, but if genotype abnormalities are detected, this means that the subject has susceptibility to disease and body response that might cause the disease to become more severe. Normal status in this subject might be influenced by good of oral hygiene status, good of nutrition, and maybe good of lifestyle.
Excellent. And last, probably, Dr. Linda, what dentists can learn from this PDR polymorphism. Yeah. What dentists can learn? What can we do as a dentist regarding this PDR polymorphism?
The dentist or clinician can take preventive measure again patient with genetic disorder, such as maintaining a good oral hygiene index of improving nutrition, especially calcium intake and healthy lifestyle.
Okay, so they are all associated with chronic periodontitis.
Yes, that's right.
Yes, doctor. Thank you so much, ladies and gentlemen. Since we are now almost finished up, I would like to wrap this session with conclusion that the high incidence of periodontitis in Indonesia probably associated with PDR gene polymorphism. And this PDR polymorphism causes the reduction of calcium and phosphate in the blood and will disturb the body bone density, which then will lead to reduction of immune function and then bone reception. And this is all contribute highly to the chronic to the periodontitis, chronically or acutely. And in the end of the day, in the future, we hopefully that the treatment of periodontitis can be alternatively given by considering the PDR polymorphism. As Dr. Nurlinda say, chronic periodontitis will be also improved if you can suggest patient with a good nutrition and calcium to compensate of this PDR polymorphism in our Indonesian, especially in South Sulawesi genetic. Thank you so much for your attention. Thank you so much, Dr. Nurlinda, for a very excellent research that you show us. I hopefully in the next future, this research will be continued with more information about our genetic behavior.
Thank you.
Thank you so much, and I leave it to MC, Dr. Yaya. Dr. Yaya. Can you hear me? Okay, then I will. Dr. Yaya.
Sorry, Dok. Yeah, okay. Ladies, okay, ladies and gentlemen, distinguished participants. Now we are going to announce two best questions to get one bottle each of them from OxyFresh, Fresh Breed from PT OHW Indonesia. Maybe for Dr. Linda or Dr. Ernie, you can choose two best questions for this session.
Silakan Dr. Linda, can you see your chat?
The first winner maybe I forgot who the question maybe about polymorphism, difference polymorphism and mutation.
So it's go to Dr. Jet Lolong.
Yes, and the second winner Dr. Aceh Habibi.
Dr. Aceh Habibi.
Yes.
Congratulations both Dr. Jet Lolong. I think we have also Dr. Irfan Hidayah and Dr. Aceh, but they can share their mouthwash. Thank you so much, Doctor.
Okay, for the participant, please contact our contact person after this event ends today. Thank you. And ladies and gentlemen, that's all for our first session. Thank you for Dr. Ernie for your kind leading the session. So now we are going to certificate submitting for our speakers and our moderator today that will be delivered by the chairperson of 6 ICoBTD to Mrs. Christine Anastasia Rovani, Dr. Gigi, Spesialis Konservasi Gigi Konsultan. The floor is yours.
Thank you very much, Dr. Yaya. And thank you very much for Dr. Linda Hamrun for your very great presentation. And as an appreciation, we provide a certificate to you. Thank you very much, Dr. Nurlinda.
Thank you very much, Dr. Eti. Thank you for leading me.
Thank you very much, Dr. Nurlinda, and also for our moderator today, Dr. Ernie Marlina. Thank you very much for leading this session, Doc.
A pleasure, Doctor. Thank you. We both so happy. It's a wonderful weekend. We got 3 medals, 3 gold medals, 1 bronze. It's a great achievement. Thank you so much, our lecturer, for all the teaching and your patience. Thank you, Doctor.
Okay.
Thank you very much for Dr. Christine and Dr. Ernie as a moderator, and also the speaker, Dr. Gigi Norlinda Hamrun, for the great presentation as discussion. Okay. Now we are going to enter the second session, and for the second session will be led by the moderator, Dr. Gigi Acing Habibi Muda, Dr. Gigi PhD spesialis prostodonsi. Dr. Gigi Acing Habibi Muda, born in Wajo at February 7, 1981.
Okay, well, thank you very much, Dr. Yaya, for giving me time to lead this session. So also, as the first moderator said that we would like to congratulation to the Faculty of Dentistry, Hasanuddin University, as last night we got good news that our student in PIMNAS got the 3 gold medals and 1 silver medal for the research and other category. So congratulations to Hasanuddin University Dentistry Faculty. And then also this is the last day or the Thursday of our international meeting. So this session we're gonna have a lecture or sharing from Dr. Harley Prabowo, MSc PhD SP Pros, about the ocean integration. So I would like to say thank you very much. So Dr. Harley, are you there? Can you hear my voice?
Yes, I am.
Yeah, thank you very much, Dr. Harley. Good morning.
It's a pleasure. Morning.
Yeah, we are sorry because this early morning in Surabaya. I think it's 8 o'clock.
Not really, 8 o'clock in the morning. Still okay for me.
Yeah, thank you very much, Dr. Harley, for accept our invitation for being a presenter, main lecturer in our meeting. Thank you very much for your time.
Thank you.
So yeah, because we have a limited time, so please, organizing committee, can you show the CV of our presenter today? Yeah, well, thank you very much. So Dr. Harley is a lecturer in Erlangga University, Faculty of Dentistry. I know that he have a lot of publication, and also he has focused on the ocean integration topic. So because we have a limiting time, Dr. Harley, so please, the floor is yours.
Okay, thank you.
Yep.
Thank you, Dr. Aking. So I'll try to share my screen. Can you see?
Yeah.
My
Yes.
screen?
Yes. Yes, Dr.
So good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. So today I'm going to discuss about ocean integration. Actually, ocean integration has been told to us many years ago, but in my opinion, there is a shift paradigm between the one that stated by Professor Brandemark and now. Firstly, I'm going to, why it stopped my screen? Okay. Throughout the history of dentistry, clinician and patient have struggled with option for replacing missing teeth. As you know, that missing teeth is not comfortable, it's not aesthetically acceptable. So, and treatment options have evolved from the acrylic denture to metal framework, from removable partial denture to fixed partial denture. The aim of this effort is to restore stomatokinetic system to normal function, i.e. Speeds, so we can talk correctly, word by word, aesthetic, so we look more beautiful and more handsome. The contour makes us look younger, sometimes like that, and for comfort. And this become a goal of recent prosthetic dentistry. This is the conventional denture. We all know that this denture hold on the mouth, in the mouth, with a vacuum mechanism. But after a certain period, this denture become loose. Then we need something, or maybe not loose. First, it need a replacement because it's damaged, cracked, or everything. Then people try to introduce things with a metal frame, something like that. But the problem is not only is strong, but how a denture can stay on in the mouth. So some people try to make to mimic the vacuum in the initial denture with the plastic like this, you know. This serves as a vacuum, makes the upper denture can stay better. For partially edentulous, we can make a metal frame like this, or if we prefer, or if the patient prefer, they can have a bridge like this, which is, I think a bridge is more comfortable and aesthetically is better than the metal frame denture. An attempt to gain an accuracy from jaw commenced before the mid of 20th centuries. The armamentarium used is later known as a dental implant. Prosthesis on implant popularity raised up after mid-20th century and became a standard of service in dentistry at early 21st century. So dentists try to utilize implant at the beginning of 20th centuries. I think in 1934, many times of implant has been used. And the material also varies. Many materials has been used for these purposes. That include gold, silver, copper, etc. When the denture stops surfing because it's loose, some people try to make an anchorage inside the gingiva, the gum. And this is the anchorage look like. Some people name it as a button snap, and also, or they call it a subgingival implant. The fixed things, they put like this. There's many kind of implant, this subperiosteal implant, rivet implant, blade implant, is all this. So this is subperiosteal implant, okay? This is blade implant, and this is rivet implant. This kind of implant has been used many years ago. It works, but not always success. Sometimes it fails. And this is also combination between subperiosteal implant, also subgingival implant. So they try many things to make fixed restoration or fix a denture. A bridge like this, a blade implant like this, and also being used. This blade implant is popularized by Lin Kao in 86 or before. And many research has been conducted since. Evolution of implant take place. So the implant is evolved from the one introduced, like, you know, before we saw previously they use subperiosteal implant, they use blade implant, they use refed implant. Then they concluded with things that simplify the protocol. So the changes of the implant is in design, the shape, material, and also protocol, make things that easier. Titanium was introduced in late 20th century. So when an implant failed, they thought because the design, but at that time they didn't realize that material has a key role of the success of an implant. Currently, the demand of implant is simple, predictable, and long-lasting. And lately, I think we hope that the recent implant have better performance, i.e. it doesn't just last long, but it gives an exercise to the bone. So when the bone exercise, it becomes more compact, make the implant last longer. At this time, the popularity is become the popularity of an Indonesian implant. So the subgingival implant, subperiosteal implant, or maybe transeptal implant is not longer become a choice because the difficulty and everything. Yeah. Research for better outcome led to treat surface of implant as well as use different material. As we know that when I start learning implant, most of the implant was machine surface, which is smooth, shiny. But nowadays, the implant is rough and they have a better performance, better adaptability to bone, and has a better distribution to the bone. The protocol of implantation developed in two ways. The easy way was utilizing custom or special implant. The hard way is we make a tissue engineering. We incorporate the tissue engineering. That means when the bone volume is not sufficient, either we enlarge the bone or we make the bone higher. I give an example, the various endogenous implant and its geometry. This is when I start placing the implant in 1990. Some of the implant look like this. It's a cylinder, some with thread, some with fan. If you see, this is a fan, and this is the thread. This also was introduced, I think, in 2002. I think this is the Bicon implant. This is a screw type implant from Professor Brannemark. No, Professor Gravelman, I think. And this is the Brannemark implant. The latest Brannemark implant before it's changed with other implant. And the right one was, the last one was a blade implant. So this is the implant used in, I think during 1990 to 2000. This also implant. So the blade implant has a single post or double post. Dental implant is now a reality for rehabilitation of many challenging clinical situations. The more teeth a patient is missing, the more challenging this task becomes. Dental prosthesis service currently offer a various option, i.e. a fixed prosthesis, such as a solitaire crown, a bridge, or they can make all-on 6 bridge, or a removable one with a bar with clip attachment, or ball with rubber attachment, and many kind of attachment for these purposes. This is the example of, we call it a Dodder bar, a denture supported with 4 implant and a clip. This is a removable. And this is 2 implant with a locator. The stain. When a denture hold by 2 implant, mostly the design is actually tissue supported. So the locator, the implant, is served as retention only. This is a screw type denture. So, sorry, screw retained denture. So the denture is retained by a screw on to the abutment of the implant. The demand for implant-supported prosthesis has shifted from function only to function and aesthetic. This is the example. If you see, we can make it better for better aesthetic. Continuing research led to advanced implantology. This to include diagnostic tools, implant and shape geometry design, implant material and treatment of its surfaces, implant placement protocol, and treatment planning. As a result, an osseointegrated implant with easy protocol is achieved. So nowadays, I think previous speaker has been introduced about the use of surgical guide to place the implant in the correct position, in the right bone position, to make the implant will stay longer or as long as possible, and osseointegrate better. This is the guidelines for implant bone contact possibility. When this what they call this guidelines produced, I think about 20 years ago, the implant use is many type of implant, including cobalt chrome implant. Okay, so in most cases, it's found that between the implant and the bone has a surface or something like this, or it can bound like this. They call it distant osteogenesis, contact osteogenesis, through bone osteogenesis, and bone osteogenesis. Now we talk about osseointegration itself. The term osseointegration was coined by Professor Brandmark in 1977. At that time, he researched on microcirculation in the bone repair mechanism. And the principle is based on tissue cooperation. Okay, he started in 1977 and then concluded in 1986. Then he declared in 1986. He found that it discovered intimate contact with vital or living bone to titanium implant. So he found that only titanium can do this. Okay, no matter what grade the implant it was, but it has a good contact to the bone. The surface of titanium implant used at the time was machine surface, like I mentioned before. It's smooth, shiny, and this is crucial for dentists to gain accuracy from the jawbone, and studied currently on modification of implant material and also surface. So when Professor Brandmark placed the implant in 1986, most of the implant are long. Let's say 10, 12, 15, 17 mm in length of the implant itself. The goal is actually anchorage. The mechanism of osseointegration, mechanism of this implant become integrated in the bone can be subdivided into three separate phenomena. We call osteoconduction, de novo bone formation, and bone remodeling. The osseointegration itself depends on quality of material and surface. The success of osseointegration requires undisturbed healing of differentiated tissue toward the fixed surface neo and revascularization according to basic biological principles. So when we place the implant, it is a must, then the implant is not disturbed by any kind of movement. When I start placing the implant in 1991, when implant fail, it loose or out of the mouth, people always say that when I place the implant, it's not in the sterile condition. As a matter of fact, lately or later, we know that the reason mostly is actually the disturbance of the implant itself during healing. That's to include maybe brushing teeth, also the movement of the jaw, which is directly to the implant itself. And late 1990, they call it the primary stability. The primary stability itself is accomplished when the implant is placed in the bone in such position that it's well seated. So well seated means it's seated no matter the torque it is. Even it's only 5 Newton, that's enough. So it's not movable, and there is no things that can disturb the implant itself. Then the secondary will occur. Now, secondary stability is developed from regeneration and remodeling of the bone and tissue around the implant after insertion, and affected by the primary stability, bone formation and remodeling. So after we got primary stability, then the secondary stability occurred. The primary stability will last maybe 1 or 2 weeks, and the secondary stability after the osseointegration is achieved. The osseointegration depends on the implant surface, actually. The surface of the dental implant plays a significant role in osseointegration. The rougher the implant surface, the easier it will be for the bone to adhere to it. A wide variety of implant surfaces are available. Acid etch and sandblasted dental implant are popular choice to improve osseointegration. The goal is actually altering the surface to have better hydrophilicity. So when we use machine surface implant, the hydrophilicity as good as the rough surface implant, such as hydroxyapatite coating or this TE unite treatment. But machine surface are also still be used, and mostly now it be used for they call it temporary implant. So they put it implant in for temporary reason. So for make temporary braids. So after the primary implant achieve the osseointegration, and this implant will be removed. A machine implant surface simply refers to a manufacturing process. Again, so it's like milling. So the titanium is milled, then it's cleaned, then it's polished. Yeah. They use electropolishing for polishing the implant itself. And this one is termed as no treatment. This is actually the prototype of Brandmark implant during 1986. They make many design, but mostly is machine surface. Professor Brandmark simply see the contact from bone to this shiny surface. And this is the implant surface. When machine surface, the implant surface under the micro scanning micrographic. After the era of machine surface, they try to make a better surface with spraying a plasma of titanium. This is a coating that being used to roughen the implant surface. This is actually titanium powder, which is sprayed to the machine surface titanium. This kind of surface was good, been used in late 90 until the beginning of year 2000, and the popularity was replaced with other means of surface treatment. Currently, this treatment used to metallize non-metallic implant. This is a titanium plasma surface, but on the right one is actually under 20 micron. On the left one was 200 micron. But if you see, the topographic of the surface is matter, actually. The reason is actually we expect actually blood to enter. If it has a good hydrophilicity, the blood comes into this cleft, stay there, and remodelize and become a bone. And this will have a good contact between the bone and the implant itself. And this is a coating of titanium plasma under 150 scanning electron micrograph. Other material used for surface treatment is hydroxyapatite. This is the most widely used. It's calcium phosphate bioceramic for coating of metallic material. Initially, this material is used in for medical purposes, but in year 90, it used also for implant. The first dental implant used with this coating was Calcitech, made by Sulzer Medica. So this hydroxyapatite powder are sprayed into the machine surface titanium. This used to roughen the implant surface, also to enhance the osteoconductivity. So with this kind of implant, at that time, during 1992 to 1994 to 1998, I think, this kind of surface treatment is very good. What matter you make, what any kind of socket you make, you place this kind of implant, it will osseodegrade. The problem is only maybe the angulation is not the right, what you want. This is a very good one. Unfortunately, this kind of surface treatment only lasts for maybe 10 years. In most cases, the implant I placed in year 94 to 96 is in surface 10 years after. Probably the reason is actually the hydroxyapatite itself is not attached to the implant, so that the implant is out of the socket. This is appearance of hydroxyapatite coating surface under 150 times scanning electron micrograph. This is the hydroxyapatite integrated to the bone. You can see that this is the hydroxyapatite. See, and this is the bone. This is the implant. So the reason, maybe the reason why the implant I placed in 1994, 1976 is stopped working, actually because either this hydroxyapatite gone, disappeared, or the material used to attach to the titanium ceased work. So the different best, the other two is actually, I call it outer surface treatment. The outer surface treatment means that we make the implant itself. We start with making the implant. Afterward, we treat it outerly. So it's outside of the implant. So we make the implant slightly bigger because the rough surface. And this one is, we call it sandblasted large grid with acid add, or SLA, introduced by ITI in the late 20th century. And the research was carried out by Busser et al. In 1991. So the research started in 1991. But is produced and manufactured for implant or use in implantology, I think in the year 2000. And this is look like. So it look the same with the goal is actually both are the same. The goal is actually roughen the surface. With rough surface, it makes it's increased the hydrophilicity. And increased hydrophilicity means better osseointegration, and quicker osseointegration. And this is under scanning electron micrograph. If in the previous picture, there's a white things here. Now it's only implant with a rougher surface. If you see, this is a rough surface, which is this contact. So this type of surface treatment gives a better result than the previous one. Other type of surface treatment Many research have been carried out since Panama claimed ocean integration for vital bone leafing attached on metallic substance. Most research focus on performance changes on metallic surface. That's to include Raven surface are RPM, TE unite, laser lock, and etc. So there's many attempt has been carried out to make the surface better. We not only make the surface to alter the surface, but we also make the situation around the implant better. That's to include nitrogen spray, activated surface spray, and etc. So mostly they use to make a better hydrophilicity. And lately, they try to use a non-metallic implant, non-metallic, non-titanium for implant. How we measure BIC value? BIC, as you know, that we call it bone implant contact. Measuring the bone implant could be differ between in 1986 to now. In 1986, if we measure the BIC, we can see through the radiographic. And then we can assume with a calculation to see how many 100% is bone attached to the leafing the titanium. At that time, the surface of the implant was relatively smooth, or we call it machine surface. But current surface are rougher, makes the bone contact higher. Unfortunately, this make measuring the BIC is quite difficult. So when the implant is smooth or machine surface, we can use the radiographic. But the other things that we can use to measure the BIC, in my opinion, we can use the TOC test. But again, TOC test means this not only the implant contact with the titanium, but it's also the geometry of the implant make everything different. Okay. If you see the red thing, the red line is, we call it the BIC. So when the implant is actually smooth surface, it's easy to calculate. We can see which one attached, which one doesn't attach, and then we can make a calculation. And the result is percentage. But when the surface of the implant is rough, it's quite difficult. We just make an assumption. So with this kind, if you want to see the BIC, it's difficult with the hydroxyapatite coating because it has media between the bone and the titanium itself. This is the implant to SLA surface. So when you see that it's a rough surface, it's not even, so making the line is quite difficult, okay? Because every square millimeter, the surface contact may be different. I have an example of the good ocean integration. Okay, this is the implant I placed. Okay, you see this one, and if you see on the distal side, there's a bone formation. Okay, this because a good osteointegration make the bone exercise, so it increase the bone volume also, and also strengthen the bone. If you see previously, it's slightly it's radiolucent. This one is radiopacity. Okay. There is slightly, this is 1 year, it's after 3 years, there's slightly growth on the distal side. Current shape and geometry. So this is the axiom. This is the previous axiom. Okay, the old one, this is the, so the implant geometry also make a different, make better integration. This is the Straumann one. This is the first Straumann in 1990. Then this is both are, this is the second one after the development. I said the last one, maybe the mid of, I think 2005. And this the recent geometry of the Straumann implant. This is the bone level, the previous bone level, and this is the second one, and this is the third one. So the implant geometry also developed for a better osseointegration. Okay, this is the Bicon design in 2004. But since it has a good geometry, it's good stability, good osseointegration, and copied by other company. So this is a mega gen. So nowadays, most of the implant is look like this. You see small in the apical area, small on the cervical area, and big in the middle area. You see the Straumann, small this side, bigger in this side. Okay. The reason is actually to distribute the force, just lower the critical zone. Modification in implant placement and protocol. Previously, 3 months after extraction, 3 to 4 months loading. Implant mostly body crystal. Implant for prosthetic anchorage. Now, 3 choice of protocol. Yeah, there is immediate, early, and regular placement. 2 months to immediate body or subcrestal. Yeah, implant body placed or subcrestal. Implant for prosthetic anchorage and maintaining bone volume. In conclusion, implant has evolved from what was placed in mid-20th century. Osseointegration plays the key role for success implant. BIC cannot compare osseointegration between implant type. Current osseointegration is slightly different to what was stated in 1986, since changes on the implant material, surface, and geometry. And removal torque value, I think, is the best way to measure osseointegration. So if we want to compare one to another, we should make so the medium is the same, then we can measure. And I think the best protocol is using the removal torque test. Thank you. Mr. Moderator.
Yes,
Dr.
yes,
Aching,
doctor.
can I have
Yes.
some minutes for sharing case?
Yes, yes, sure, please.
Okay,
Yeah.
so thank you. Okay, this is my case. Yeah. I try to make, slightly easier. So I just put the implant like this. Again, you can see that bone growth, okay? So this makes the implant better. I mean, the stability of the prosthetic better later. Okay. Thank you, Dr. Aching.
Yeah. Oh, very nice presentation, Dr. Harley. So actually, I also learned so many things today from the implant, from the beginning until the recent implant. For example, the shape and geometry, and also the osseointegration process. So we also know that the study of the implant is very fast. So there are many changes over the time, and then today we got a lot of the increasing knowledge about the implant. Thank you very much, Dr. Harley, for the very nice presentation. Yeah. So actually, we still have about 10 minutes. So we're gonna have a discussion session, doctor. So I would like to read the question from the participant. So there is a question. So good morning, doc. What is the main factor that can be influence the osseointegration, and what can we do to increase the osseointegration? I think the Dr. Harley also mentioned about it. So could you please a little bit answer the discussion? Yes.
Okay. So the main things is no matter how good is your implant is, the primary stability should be achieved at the first place. Then we have to ensure that there is no obstruction to the implant when we place it. No dangers, no, what do you call it, excrete, cleaning to the gum, or maybe if we choose one-stage surgery protocol, don't touch too often, the abutment or the healing abutment. So to make the implant stable, when we have no choice, if we place the implant only solitaire, one implant, so just splint it with other teeth. So if we prefer to place the implant and immediate implant placement, immediate loading, means that you shouldn't give any force to the crown, splint with the adjacent teeth, and ensure that the disturbance is minimal. The others, is only for a better or faster osseointegration, like the SLA, the nitrogen, and everything is only make the healing process is faster. But in my experience, the three things that I mentioned previously is the important thing.
Yeah, thank you very much, Dr. Harley. So I continue the question. So doctor, as you mentioned that we need to not to touch the implants frequently. I mean, then during the osseointegration, there is a duration need for osseointegration, and sometimes the patient don't want to in the edentulous period. I mean, they want to use for example, removable denture on the edentulous. So based on your practice, which one is better, by using a removable denture on the edentulous side or in the implant side, or using a fixed denture to prevent the implant side?
Yeah. So in my experience, never use a denture which is mucosa supported on implant. That's very bad. So if, for instance, the patient is edentulous, place as much as implant as possible, not the big one, the small one, then make a bridge immediately. So that's much better than put a denture on it. So we can place the implant, maybe 10, 12 implant, small one, 3.5, 3.4, something like that. 10, 12, then put the abutment, make the, if the patient doesn't want to wait a long time.
Yep.
The disadvantages at the end, and make the force balance. So when we bite, we chew, ensure that all the force is even to all place. And eventually that we will find that after 12 implant, maybe 1 or 2 fail. So, and we can replace later. It's not so difficult.
Yeah, thank you very much. Yeah, Doctor, we still have a question in the chat room. So a participant asked about, is there any special consideration to decide which kind of implant we should use for patient with systemic condition? So she asked about, is there any special consideration to decide what kind of implant that can be used for the patient with the systemic condition?
Okay, when they call systemic, in my experience,
yeah.
When I start placing the implant during 1990 to year 2000, I have 3 options. We call it contraindication permanent and contraindication temporary. Temporary means if we can make the patient in the right situation and we can place the implant. As a matter of fact, but the condition is mostly temporary. The temporary means that the special systemic condition is actually a contraindication during the surgery. In my experience, in most cases, so for instance, I have a patient which is she's diabetic, and I just realized just a minute before the operation that she has the breath is slightly different. So, and I decided to send her to the internist, and found that she's a diabetic with a higher glucose in the blood. So I treat her for maybe 6 months under treatment, then it's normal. But the internist told me maybe about 20 years ago, she is not the right person for implant. So he said that I shouldn't place implant to her. But again, in my opinion, he was wrong. So I placed about 8 implant, put a bridge, and I saw her a bit, maybe 3 years ago. So how many years? 17 years ago, still in place. Oh. So diabetic is not contraindication. That's contraindication for the implant for the surgery. I mean,
Okay.
but after the implant osseointegrate, the prosthetic we make. So when the glucose up again, it's still the same. It has not make a problem in my experience.
Very interesting case, Dr. Harley, because as I know, and also maybe for the other dentists know that in the diabetic patient, it's difficult to get the successful implant, but in your cases, you can make a good implant for
Yeah.
Yeah, for yeah. Thank you very much. So actually, Doc, I still have some question. Would you like to answer? We still have 3 minutes.
Question. Okay,
Yes.
no problem.
Yeah. Okay. Thank you very much. So actually, I'm very lucky today. So I also can ask to Dr. Harley. So
Okay, no problem.
yeah. Actually. A parafunction activity. I would like to ask about the parafunction activity, doctor. So sometimes a patient who want to make the implant, sometimes we didn't realize that she has a parafunction activity. For example, bruxism, and then the parafunction activity can affect the failure of the implant.
Correct.
So yeah, so how to diagnose a patient with this parafunction before we conduct the implant? I mean, how to diagnose that this patient has this habit, and then how to maintain and how to deal with this habit after the implant placement. So do you get my point?
Yeah. Okay. You know, I found that several cases that the bruxism occur after the implant placement. For instance, let's say the patient has upper and lower denture previously, but after we place the implant, make a brace, then the bruxism occurs. You know, it's occur, but it's difficult. So when I try to solve that problem, I just realized that the height, the vertical height is slightly lower when before so we try to make the bridge slightly higher just to reduce the bruxism. So that's what I'm normally do when I found the patient become bruxism after implant placement.
Yeah. Thank you
it's
very much.
difficult to know because if the patient wearing a denture, we cannot know, you know, because the one that will lose with removal denture is actually the bone.
Yeah.
Okay.
Sure.
The denture will not lose, but the bone will lose. So the reception will, you know, something like that. But with the implant, it becomes many things. The denture abraded, the porcelain crown break, you know.
Yeah.
Something like that.
Yeah. Yeah. Maybe also in the first anamnesis, maybe we need to deep anamnese to the patient. But yeah, thank you very much, Dr. Hardy. So it's much help to treat the patient. So one more question, doctor. Is it? Yeah.
No problem.
Yeah. As we know that there is a direct loading implant or direct immediate loaded implant, and then there are also conventional loading implant. So based on the geometry, of the shape of implant, is there any different that which kind of the geometry or shape of implant can we use for the immediate loading implant, or which one of the geometry of the shape of implant is suitable for the conventional loading implant? So do you have experience about it?
Yes. nowadays more and more patients prefer they have no time for edentulous, they
Yeah.
prefer they come to the office immediately they have a tooth,
Yes.
sometimes it's difficult, but there's a kind of implant that we can use. My teacher, my mentor, Professor Gravelman, has a product named screw type implant. This is non-oseo integrated implant. So like the one that belong to Professor Brandemark. So if we use that kind of implant for immediate implant placement for an immediate loading, it can do, but maybe on a certain period they will lose, but doesn't matter. This is a temporary implant. So normally I will place maybe four screw type implant, then make a bridge, then place another 4 implant, conventional implant without interruption. But in the single case, I rather wait. So after extraction, I wait for maybe 3 weeks for early implant placement, rather than make implant placement immediately. Because I have a bad experience, immediate implant placement and fail. And I think most cases, the reason is actually the infection after extraction. Or maybe I didn't clean enough, the socket is not clean enough to place my implant. So I prefer now early placement. So if I have a case that solitaire missing, one tooth missing, I rather put the implant conventionally than make an adhesive bridge for temporary.
Yeah. Thank you very much.
Many material for adhesive bridge currently.
Yeah. So unfortunately, we just got the time, doctor. Actually, we have for me myself, I have a lot of question actually.
No problem.
But thank you very
from
prosthodontic. Yes, Makassar, doctor.
Oh, I can go there.
Please
Professor
come.
Dharma is my best friend.
Yeah. My mentor, doctor.
Yeah.
Yes.
Send my regard to him.
Yes, sure. So thank you very much, Dr. Harley, for the very nice presentation today. So as a rule of the organizing committee, we will give a souvenir for the participant who has a good question for today. And then, so for as our appreciation to Dr. Harley, so we will give, okay. So the best question is coming from, so actually we have only 2 person who, So could you please choose, Doctor?
Okay. All the question is good, for me it's very good.
Yeah.
But I like the one who asked about the systemic condition, because in my opinion, it's most of my patients come to me because they have a limited condition and then situation that special that the other dentist cannot solve the problem. So I think that kind of question becomes the number 1.
Yeah. Okay. So
I don't know who asked who was it.
Dr. Gigi Sumiati. Yeah, Dr. Gigi Sumiati asked about the systemic condition, and the other one
is about the protocol.
About the protocol, yes.
Yeah, the protocol. Which one is better than for a certain implant?
Okay. So the Dr. Nur Hikmah. Okay. So Dr. Harley, we have a certificate that we will give to you. So, but now we give you by online, and then we will send the letter.
Thank you very much.
Yes. So I return to the MC, please.
Okay.
Thank you very much, Dr. Harley.
Okay.
Thank you.
Thank you. Okay, ladies and gentlemen, distinguished participant. Thank you, Dr. Aching, for your kind leading the session. So now we are going to certificate submitting for our speaker and our moderator today that will be delivered by the chairperson 6 ICoBTD to Mrs. Christine Anastasia Rovani, Dr. Gigi Spesialis Konservasi Gigi Konsultan. Please, the floor is yours.
Thank you very much, Dr. Yaya. Thank you very much, Dr. Harley, for your participation as a keynote speaker for a very interesting and inspiring lecture today. And as an appreciate, we provide you a certificate. And also for our moderator today, Dr. Aching. Thank you very much, Dr. Aching, for leading this session. Thank you very much, Dr. Harley. Thank you very much, Dr. Aching.
Thank you, Doc.
Thank you.
Thank you very much, Dr. Christine, Dr. Aching as the moderator, and also the speaker, Harley Prabowo, Dr. Gigi, Master of Science, PhD, Specialist Prosthodontic Consultant, for the great presentation and discussion about osteointegration in current paradigm. The session was really inspired our knowledge. Thank you, Doc.
Thank you. Oh, by the way, can I correct? I'm not a consultant yet.
Oh, okay, sorry, Doc.
Sorry. Thank you.
Thank you, Doc.
It doesn't matter for me. Okay, thank you.
Okay, now we are enter the third session, and for the third session will be led by the moderator Mareta Ningtyas Dwi Ariana, Dr. Gigi, MCAS, PhD, Specialist Prosthodontic Consultant. A brief introduction of the moderator. Born in Surabaya, March 17, 1980, graduate her dentist degree in Universitas Erlangga, Magister of Dental Health in Universitas Erlangga, PhD program in Hiroshima University, Japan, and prosthodoncy specialist in Universitas Erlangga. She has many publications and articles according to her expertise. For moderator, the floor is yours.
Okay, thank you very much, Dr. Yaya. Good morning, Professor Cheng.
Hello.
Nice to see you again. Because last time you also talk in Erlangga University.
Oh, I see. Okay.
Yeah, with Dr. Aksa.
Oh, okay.
Okay, so now in this occasion, I will be your moderator, Professor
Thank you,
Cheng.
right. Yeah.
Okay, good morning, everyone. The Honorable Dean and Vice Dean of Faculty of Dentistry, Hasanuddin University, the Honorable Dean and Vice Dean of Faculty of Dental Medicine, Universitas Erlangga, and the Honorable Dean and Vice Dean of Faculty of Dentistry, Brawijaya University, respectable the Chair Lady of 6th International Conferences on Biophysical Technology in Dentistry, the Honorable all speakers of the 6th ICoBTD, especially our speaker in this session, Professor Dr. Cheng Hui-Ming, and the Honorable all professors, doctors, and all participants of the 6th ICoBTD. Assalamualaikum warahmatullahi wabarakatuh. First of all, let us thanks to Almighty Allah Subhanahu wa Ta'ala, because of His blessing we are able to join in these conferences. And secondly, salawat and salam also delivered to our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from the darkness into the brightness. Ladies and gentlemen, my name is Mareta Ningtyas from Faculty of Dental Medicine, Universitas Erlangga, Surabaya, Indonesia, the host of this session. And I'm very pleased to see you here and welcome all of you to 6th ICoBTD. And ladies and gentlemen, in this very special occasion, Professor Dr. Cheng Hui-Ming from Department of Physiology, Faculty Medicine, University Malaya, Malaysia, would like to present his research with the title Dental Physiology Bites. And before Prof. Cheng deliver his presentation, let me to read briefly his curriculum vitae. Professor Cheng has taught physiology at the University Malaya in Kuala Lumpur since 1986. Okay, thank you, committee. But I will continue. Okay, Professor Cheng also has an interest in understanding how students think, learn, and in helping them unmask misconception in physiology. And his book include Thinking Through Physiology and Defining Physiology. And Professor Cheng is also the initiator of the annual International Physiology Quiz. Okay, Professor Cheng, let me inform how to present. So we'll be going on first. Professor Cheng will present for 45 minutes. Then continue with the question and answer session for 15 minutes, then followed by conclusion. To all participants, if you have any question, please write down in Q&A column. Now, allow me to welcome our keynote speaker to deliver his presentation. Professor Cheng, the screen is yours.
Thank you, Dr. Mauritaning Tias. Yeah, so it's nice to meet up again. Yeah, I gave the talk in Airlangga in May, I think, 1st of May.
Yes,
Yeah.
yes,
And
of
in fact, some of the slides I'm going to show today is taken from that talk. Yeah.
It's okay.
But yeah. So thank you for inviting me to a very, obviously a very dental audience. I'm actually in the medical faculty, but I also teach dental students. So this morning, I basically wanted to highlight, and I hope there can be a follow-up discussion of how we can better focus our teaching of general physiology for our medical students. And it's interesting during the question time, listening to Professor Hali, that there's an important role of having the dental professional to know about systemic disease. So the understanding of diabetes mellitus and the case that was mentioned. So I think this leads quite naturally to my focus this morning. So this will be a less technical talk because this is an educational talk, but I hope that the teachers here, those of you especially involved in teaching general physiology, can interact with me in a future conversation. So let me just share screen. Okay. Can you see this on your side?
Yes, Prof.
Yeah, okay. So I've decided to call this dental physiology bites. And this is just, it was supposed to be a video of a chattering teeth. And the name here, Caleb, is my grandson who just turned 1 year old. So, so let me show you, those of you who have not been to our beautiful green campus, this is what it looks like at one of the entrance. This is a bird's eye view, or now we call it the drone's eye view. And we have some animals floating in front of the university lake. So, and I remember that my last overseas trip pre-COVID days was actually to Makassar. University Hasanuddin organized a physiology conference. So obviously the last 18 months have been very quiet, and I hope that travel can resume soon between Malaysia and Indonesia. At the moment, we can leave Malaysia, but when we come back, we have to be quarantined at least 1 week. So we hope that the vaccination will be in good progress and the exchange face-to-face physically can continue. So, so this is basically, I've been teaching medical students mainly, but also dental students for almost 30 years now. And in most dental faculty, and I'm not sure what is the situation in Indonesia, in Hasanuddin, most of the physiology teaching is done by medical lecturers. And so they divide their time. And if the medical lecturer is busy, very often they don't have the time to summarize and simplify the physiology information for the dental students. And very often, this is feedback from the students, there's often too much physiology being taught that is needed by our future dental professional. For example, I posed this question to some of the freshie dental students who've just entered this year into University Malaya. So I just asked them, why do you think dental students should learn renal physiology? So obviously these are new students, so they may have some general knowledge or they may not have. But I should have told them without Googling, what is your opinion? Should we teach, how much of renal physiology should you learn as dental students? Obviously, in future, most of their interest is above the diaphragm, the respiratory system, the mouth and all that. So interestingly, I got some replies, and obviously being very keen students who are just entering dental school, and I didn't tell them without looking at Google or research. So these are some of the replies I got. So I just put it up. So this is one Chinese girl regarding the question, and she gave quite a good answer. And she says here, based on my simple research, So this is actually quite nice for these new students to be able to now easily try to see why they do need to know some basic knowledge about renal physiology. But of course, things like the renal countercurrent physiology, how much of that should we teach? Because that's always a very convoluted, complex mechanism. And the next student, interestingly, also gave the reply, and you notice that the answers are almost similar. So obviously they must have gone to the same Google site. But I commend them because this is one of the ways in which we can encourage our dental students to think for themselves. And the chairman mentioned that this is one of my focus in my teaching, to get students to think through physiology. What is the relevance of anything that they learn as a medical students? And of course, we're thinking about dental students. Why am I learning this function of the kidney and how does that help towards my future professional career as a dentist? So this process of doing some self-directed linkages is, I think, quite commendable. So interestingly, and these are just some samples of the answers that I have received. So, of course, I think one of the major area in physiology that definitely should be emphasized is obviously the cardiovascular system, as well as the circulation to the brain, the cerebral circulation. And of course, there are many interesting features about these two unique circulation. So that obviously must be given a greater role. So Dr. Marita Ningtyas would obviously recognize this slide from my talk in May. So at that time, I gave a talk to the dental students as well as colleagues about the neuroendocrine control of blood pressure. So I'm just going to show you some examples. So obviously we teach about short-term blood pressure control, long-term, as well as the intermediate term. And I emphasized during that talk that even for dental students, we need to help them to integrate between short-term, long-term, and intermediate term. They are not sequential events. And obviously, right at the bottom here, long-term control of blood pressure, again, here, this is the role of the kidneys. The kidneys are involved in blood volume control, and this is obviously linked to sodium balance control. And so indirectly, the kidneys are very important together with the cardiovascular system in maintaining normal blood pressure. So when we teach blood pressure to the dental students, the role of the kidney, what I call the cardio-renal integrated control system, should be emphasized. So next slide is just to show this transcapillary shift. And this was a model of a tooth that I was given as a gift when I was at the dental student event in 2019 in Jakarta. So this shows you obviously the capillary. Pi C is the oncotic pressure, and PC is the hydrostatic pressure. This is to tell you that in the intermediate term, as the sympathetic constrict the arterioles, the drop in the hydrostatic pressure will then lead to a net Starling's force, which favors reabsorption of fluid. And so this actually is an intermediate way in which the vascular compartment is preserved during hypovolemia. So what about hormones? In the whole area of endocrine physiology, obviously some are more obvious when we think about adrenaline and noradrenaline. This is linked to the sympathetic system. But what about the other hormones? How do we integrate this for our dental students so that they can appreciate the role of hormones in their dental professional career? So these are obviously the different types of chemical hormones, peptide, neurohormone, steroid from the adrenal gland, and the catecholamines. So I'm going to show you a slide that was presented in May, and to show you that we can present a more concerted picture so that it is more relevant not only to medical students, but also to dental students. So here is a picture I like to doodle. So this is again the same tooth. So this is showing you the neuroendocrine pathway whereby some of these major hormones I just mentioned, aldosterone, angiotensin 2, adrenaline, and cortisol. So two of the major ones comes from the adrenal cortex, aldosterone and cortisol. Aldosterone is involved in blood volume control. So obviously, this is important to know for dental student, blood volume, blood pressure. Adrenaline obviously affects both the heart rate as well as the contractility. And the black line here is the sympathetic stimulation. So this is the sympathoadrenomedullary pathway for secretion of adrenaline. And this other black line here is showing you the branch of the sympathetic nerve. We call it the renal sympathetic nerve that increases renin secretion, and that eventually leads to angiotensin 2. And angiotensin 2 then stimulates aldosterone. So all these different hormones can be integrated into a summary picture. And then obviously we have cortisol. So cortisol alone do not have a direct action in vasoconstricting or vasodilating the blood vessel, but it is important to prime the blood vessel. So we call this the vasoresponsiveness of the blood vessel. This is under the priming of the glucocorticoid. And so all this, I think, can be integrated and present it. And of course, the role of the hormones is important. The region of the head, the brain, the hypothalamus, and this is an example of what we call the hypothalamo-pituitary axis that students need to know. Okay. So in order to address this question, how much of physiology do we need to teach, and how can we progressively fine-tune our teaching of physiology to the dental school? We decided to initiate an event, and using that event and platform, we are progressively compiling questions that are more related and of more interest to dental students. So this event was initially called Interdental because it just started in Malaysia with our 10 to 12 dental school. So we started in 2015, and in the last few years, this Interdental has become international dental because we were attracting dental students from dental schools in the Asian region, and they have come to join us in Malaysia until 2019, the pre-COVID year. So 2020 and this year, unfortunately, 2020, we were not able to carry on. But this year, in December, the students are still very keen, and so we will have an online 2021 Interdental Physiology Quiz. And I hope that your students in Hasanuddin, as well as other students in other dental schools in Indonesia will come and join us. So the IDPQ hopes to provide a progressive resource platform for active dialogue to better our physiology teaching for future dental health professionals. So this talk is just to show you how this simple event has generated a lot of interest in the Asian region. And we expect that this year, because it's online, that we will get some teams, in fact, from overseas. They do not have to spend money to fly to Malaysia. They can join online. And so we already have one team actually that already registered from, where was this? Is it Spain or Brazil? Yeah, so we already have the students' picture. So I hope that, I'm looking forward to this year's online IDPQ. So we're expecting more countries to join us. So the next few slides is basically to show you some pictures of our IDPQ event to show you that this is now a very enjoyable event over a weekend, and we are collecting, formulating questions that hopefully can be used as a resource to better our teaching of dental students. So the first picture is 2015, where these are the organizing committee looking very enthusiastic. And every year they will design their own t-shirt. And this actually says, don't limit your challenge your limit. So that's how ambitious our students are. So this is 2015, and only 10, I think 10 or 11 Malaysian dental schools came for the event. And then we move on to 2016. This is IDPQ, and we begin to get dental students with their lecturer here coming from Myanmar. So there are only 2 dental schools in Myanmar, one in Yangon, the other one in Mandalay. And so we have a team from Yangon joining us, a few students here. These are the Myanmar students. And of course, in recent years, they've been experiencing a lot of difficulty in the country. And some of the dental students in the final year has been asking me whether there are scholarship available so that they could finish off their final year in other countries, because things are really at a standstill now in the country. So this is from Myanmar, 2016. So this is, okay, this is a group of students from Indonesia. Do they look like Indonesian? So the one in blue is actually from Ayalanga. Okay, they are now, I think most of them have graduated except for 1 or 2. One in the bright yellow, you will recognize, is from University of Indonesia. So they came as part of the competing team and taking a picture in front of our mural. This is our myocardium mural in the Faculty of Medicine. So this is 2017. This is my wife together with me. She's a great supporter of quiz event. These are again the second team of Myanmar students that came also from Yangon. We've never been able to get students from Mandalay because of the price of the flight ticket. They have to fly from Mandalay to Yangon and then to Malaysia. So again, the t-shirt, interesting t-shirt. What is a dentist? A dentist is a doctor, an engineer, and an artist. So very creative. I'm not sure whether this is original or whether they took it from the Google. So this is another team. And this is 2017. This is end of the event photo session. This is 2018. Again, organizing committee with the team members. And this is our former dean, Professor Zainal, who kindly donated the challenge trophy. So now we have a very nice pewter challenge trophy donated by our former dean. And this is our current dean, Professor Zamri, who just took over the post in the last few months. And these are some of the winning team. And obviously this is Prof. Zainal during the opening ceremony where he's carrying the defibrillator to activate the event. So these are some pictures of students from Thailand. So we have from the top dental school, from Chulalongkorn University, Dr. Soranun and the students has been coming almost every year. And this is from Konkan. Okay, Dr. Jarin and his students from Konkan. And then in the last year, 2019, the last time we could have a face-to-face, we begin to get students from Vietnam. So over there, they call it by this name. I think you all will be familiar. This is more in line with the tradition from the Russian curriculum. And also, not only from Vietnam, but also from the Philippines. For the first time, we have a team from the Philippines. So it's becoming quite exciting. And of course, COVID interrupted that event last year. But this year, our students, they were ambitious and said, we must carry on. And so this year, before that, let me just show you some samples of the question that we asked. And we now have a bank of dental physiology question. So for example, here, patient in dentist chair says, my bladder is full. He wants to go to the washroom. And he just mentioned, I think my kidneys secrete a lot of urine. And of course, the dentist who still remember his physiology well, your kidneys does not secrete urine. Can you explain why the dentist is correct? So this is part of the quiz question. And this is because in the renal handling of water, there is no tubular secretion of water. It's basically filtration minus reabsorption. One question on endocrine. What is the action of aldosterone on the salivary glands? So obviously, most of the time, we think about aldosterone in renal function, but here we want to focus on the salivary gland and so on. So 2 more questions. Patient has gastric pain in the dentist chair. Dentist gives some milk. And then obviously, without realizing it, the patient eventually had some diarrhea because of milk intolerance. So the question is on what is the physiology behind the osmotic diarrhea experienced by this dental patient. And the last question sample here is capillary action. Net Starling's forces obviously is important throughout the body. And here we focus on the salivary capillaries and ask students to compare the Starling forces in the kidney and in the saliva. So obviously in secretion, the net Starling force must be different than the net Starling force when we think about the renal proximal tubular reabsorption. So this is how we try to gear dental students to think about how learning basic physiology mechanisms can be relevant to all areas in their learning. So I should mention that the Indonesian team has been coming, as I said, from 2016 onwards. And as a result of that, the students were very keen to initiate their own national dental quiz. So we actually have the first one in 2019. And this was quite successfully done. I think we had, almost 20 dental schools coming. And I was privileged to be the quiz master there. And of course, after that, COVID just diminished all activities. So we've not been able to continue this. So this was actually named after, I was told, one of the founding dean of the dental school in University Indonesia. So this was an exciting event where I had the privilege to network with the dental physiology teachers as well as with the dental students. And there was a team from not Hasanuddin, but from the other dental school in Makassar. I can't remember now the name. And I'm still in contact with the students in Sulawesi as a result of this event. So, so this is one of my main concern, not really concern, but a proposal that if more dental schools can actually directly employ dental lecturers to teach physiology, I think it would make dental physiology education more relevant to dental students, because the dentists or dental lecturers can use many examples in clinical dentistry to highlight the importance of general physiology, because as medical lecturers, we don't have enough examples from dental sciences. So, and I have to say that we've been writing a collection of books based on our years of teaching. So this is a series of books by Springer, Physiology Question-Based Learning. So this is obviously for medical students as well as for dental students. Just to say that Springer has now shown interest, and they've actually asked some of us, including myself, to write a book on dental physiology. So the book is still in process. We've all been very busy, and because COVID has caused us to be even more busier, trying to shift to online system. So myself and two other of my colleagues have hopefully trying to start writing and finish the dental physiology book by the end of next year. So I think, so this is my last slide. So this is basically, so I hope that when we can make dental physiology more exciting and more engaging for the student. So this is a tagline: physiology makes me salivate. And this is a picture of my grandson recently when I visited him and the family in Sabah. So perhaps there will be a dentist in the coming future. Thank you very much for listening.
Okay. Have you finished, Prof. Chen?
Yes, I finished, yeah.
Okay, sorry. So sorry. Okay. Okay, so ladies and gentlemen, we already listened the presentation from Professor Cheng. So now we will continue with discussion, so question and answer. So if you have any questions, so you can write down your question in Q&A column, or can the participant ask directly, Professor Cheng?
Yes, in fact, that would be nice to be able to
Okay.
see them. Yeah, that would be nice. Yeah.
So maybe if you have any question, participant. I see that the Dr. Aksa also joined in this meeting.
Hello.
Dr. Aksa, good morning.
Oh yes, hello, Dr. Aksa. Good to see you.
Dr. Aksa.
Sorry for being late joining the session.
That's okay.
So Dr. Aksa, could you please maybe you have a question or something to discuss with Professor Cheng?
Yeah, I think you recognize some of your students. I think they're final years, right?
Yeah,
Some
yes,
of the
yes.
students.
But
Yeah,
now,
yeah.
one of them is my resident, Professor Cheng.
Oh,
Now, yeah. The first one in the first line in your photo.
okay, yeah.
Dr. Valerian. So now he's in a prosthodontic resident.
Oh, fantastic. Please say hello to him. Yeah.
Yeah, I will. So, okay, maybe participant, do you have any question for Professor Cheng? Dr. Aksa, maybe you have a question about the dental physiology bite?
Not really dental physiology, but I follow your last lecture in University of Malang a few weeks ago, Professor Cheng.
Oh, okay, right.
Yeah.
Yeah.
You mentioned that no matter how much we eat both calcium and kalium, our body will regulate the calcium and kalium by regulating the function of the kidney.
Right. Yes.
It's a little bit triggering for me because as far as I know that many nutritionists ask us about consuming much of kalium rich food like vegetables and fruits, right? So based on your explanation, is the consuming of much calcium rich foods like vegetables and fruit beneficial for our health?
Yeah. So Dr. Aksa was referring to the talk I gave in Malang, I think 2 weeks ago. This was basically focused on the renal function. And of course, this is of importance to dental students also, because I focus on the two cations, sodium and potassium. So the question was, the point I made was that in a normal person, there is not much worry about even if you consume a high potassium rich food or a high sodium. Of course, I think in anything, if you chronically are on high sodium, high potassium, long term, we're talking about many years, but in the short term, an acute intake of a high sodium diet, which is obviously present in our Asian delicious food, or even in any diet will contain excess potassium. So it shouldn't be a problem. That was my main point. But obviously, if it is chronically high potassium, high sodium, perhaps the situation may be different. Yeah. So I think we're talking about immediate response, acute response. So if your hormonal system, your renal function is normal, it will always secrete and excrete excess potassium. And the sodium balance is very well controlled in an integrated way by the kidney. Yeah, using a family of hormones. The main one, obviously, is the renin-angiotensin system.
So it means that it is not important for us to avoid much natrium in food?
I think that would be the general. That is my opinion. Unless you have some underlying cardiovascular problem, if you are healthy, you are a young person, I don't think you should really be too worried about enjoying food, because most of our Asian foods are obviously have more sodium than necessary. But of course, if you are health conscious, you can obviously try to minimize the salt. But the point is that as a young person, if you're healthy, you exercise and all that, I don't think there's much worry about depriving yourself of some delicious food. And food is always delicious because of salt.
Oh yeah. So in the term of the normal physiology, it doesn't matter how much.
Yeah. Yeah, because those individuals with hypertension, now we use the term salt sensitive individual. So there's some genetic contribution whereby, for some reason, they respond more pathophysiologically to excess salt in the diet. But for the non-salt sensitive individual, doesn't seem to be a problem.
Okay, Dr.
Thank you,
Aksa.
Dr. Cheng.
Okay, is there enough, Dr. Aksa?
Very clear. Thank you, Professor Cheng.
Okay. Thank you very much, Dr. Aksa. So, Professor Cheng, I will read not a question, but such a suggestion from Dr. Saryuda Widyastuti. So she write, very great presentation, doctor. I just want to make a suggestion that it will be very nice if there will be a collaboration between dental physiology department and medical physiology department in Hasanuddin University that can make some work together to make a book like yours.
Okay, I think that would be a good idea. I'm always hoping to link up with colleagues who are keen to write. Yeah, so we can think about that. We can and obviously I think this can be a progressive thing. You can build up. Especially, I'm interested to link up with dentists who are keen to write, because I'm not a dentist. So we can try to think of examples from clinical dentistry and how we could write a little short scenario and introduce physiology question.
Yeah.
So that would obviously be useful.
Yeah.
So who is this lecturer? Please contact me. We can follow up. Saryuda.
Yeah, Dr. Saryuda Widyastuti.
Yeah. So please get my contact from the organizer. Be happy to hear from you. Yeah.
Maybe Professor Cheng, not only with Hasanuddin University, but also with Airlangga University, maybe.
Yes, certainly. Yeah.
Okay,
So actually, so with regards to that dental physiology book by Springer, actually the publishing agreement has already been signed. But we've been busy, and of course COVID came. We've been maybe a bit lazy too. so the agreement was signed last year, the dental physiology book. But with all my colleagues are busy. They are my younger colleagues. Yeah. So now they get involved with the SOP, the KPI, a lot of documentation. So sometimes you don't find time to write. So, but we're hoping to be able to get involvement of dental lecturers in obviously, but also other people who are keen to write. And so we can compile examples of that and maybe included as part of the book. Yeah. So it could be different chapters if you want to contribute, if you have experience with using basic physiology in helping students to appreciate. Yeah. So I think that would be nice. Yeah.
So it will be a great book. Collaborate between
so
Malaysia,
it could be a bigger book if there are more examples from dental lecturers. Yeah. So I think this will be an exciting thing to pursue. Yeah. Definitely.
Okay, thank you very much, Professor Cheng. So maybe if there is no question, can we close this session, yes. Professor Cheng? Okay, so ladies and gentlemen, we finally come to the end of this session. Before I close the session, I would like to take the conclusion from what Professor Cheng has presented. So teaching dental student physiology is quite commonly done by medical lecturers. There is often too much physiology taught that then is needed by future dentists. So also if dental lecturers can teach physiology, relevant application to dental sciences can be effectively used. The International Dental Physiology Quiz, IDPQ, was an initiative to address this issue in dental physiology education, and the IDPQ hopes to provide progressive research and platform for active dialogue to better our physiology teaching to future dental health professionals. So this is the end of our session with Professor Cheng from Department of Physiology, Faculty Medicine, University Malaya, Malaysia. Thank you very much, Professor Cheng, and all the participants of 6 ICoBTD. Stay healthy, stay safe, and have a great day. See you in the near future. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Professor Cheng.
Okay, thank you. Right.
Thank you, Dr. Cheng, Dr. Mareta. Okay, ladies and gentlemen, the distinguished participant. Now we are going to announce 2 best question participant session to get one bottle each of them from Fresh Bread from PT OHW Indonesia. Maybe for Dr. Mareta and Dr. Cheng, you can choose
Yeah.
the participant.
I think there,
Maybe Professor Cheng will choose.
Professor Cheng.
So
there
please,
was only
Professor
there only one question? Am I
only
right?
one question. Yeah, one
Yeah,
question
so,
from
okay.
Dr. Aksa and also one suggestion from Dr.
Oh, yeah, okay. So
yeah,
Dr.
okay.
Aksa asked the question.
Yeah.
So we'll put the first winner as Dr. Aksa. And the second winner, it is a good question. How can we proceed from here to continue? I think that's always quite important so that the session doesn't end here, but that we follow up on. Yeah, so that's also an important question by Dr. I'm sorry, I cannot remember.
Dr. Sari Yuda.
Yeah, okay.
Yeah. Okay. So congratulations, Dr. Aksa and also Dr. Sari Yuda.
Okay, thank you for Dr. Maret and Professor Cheng. And that's all for our third session. Thank you, Dr. Mareta, for your kind leading the session. And so now we are going to certificate submitting for our speaker and our moderator today that will be delivered by Wakil Dekan 1 Hasanuddin University to Mr. Professor Dr. Edi Mahmud, Dr. Gigi Spesialis Prostodonti Konsultan. Please, the floor is yours. I'm sorry, Prof.
Hello, thank you very much. Yeah.
Prof. Edi,
Prof.
maybe
Edi,
you can
Okay.
unmute.
Thank you very much for Dr. Prof. Cheng to the nice presentation today. I would like to give you a certificate as a keynote speaker. Thank you very much.
Thank you.
And second certificate goes to Dr. Marita Ningtyas. Thank you very much.
Thank you very much,
and
Prof.
Dr.
Edi. Yeah, thank you. Thank you very much, Prof. Edi.
Thank
Thank you
you
very
very
much,
much.
Prof. Cheng.
Yeah, so just a minor correction.
Yeah.
My last name has a G. It's M-I-N-G.
Okay.
Yeah, so you can
And also for me, not Ariana but Ariani. Okay.
Yes,
So,
yes.
okay. So,
Right, thank you. Right.
Thank you.
thank you, Professor Cheng.
Okay.
See you.
Bye-bye.
Bye-bye.
Okay.
Yeah,
Bye-bye.
thank you, Professor
Thank you
Edi.
very much.
Yeah, thank you.
Thank you, Prof.
See you next time.
See you.
Bye-bye.
Yeah.
Bye-bye.
Thank you very much for Professor Edi, Dr. Mareta as the moderator, and also the speaker, Professor Cheng Huemin, for the great presentation and discussion about dental physiology bites. The session was really inspire our knowledge. And now we are entered the fourth session, and for this session will be led by the moderator, Irfan Sugianto, Dr. Gigi, Master Medical Education, PhD. A brief introduction of the moderator, his undergraduate and profesi dentist in Hasanuddin University, Master of Medical Education from Universitas Gadjah Mada, Yogyakarta, PhD program from Okayama University, Japan. Currently, he is a chief of Oral Radiology Department and a chief of Dental Education Unit of Faculty of Dentistry, Hasanuddin University. He has many okay, I'm sorry for the interrupted. Maybe while we are waiting for the speaker and the moderator, maybe we can see the commercial break. Okay, now we are enter the fourth session, and for this session will be led by the moderator, Irfan Sugianto, Dr. Gigi, Master Medical Education, PhD. A brief introduction of the moderator. He's undergraduate and professor dentist in Hasanuddin University, Master of Medical Education from Universitas Gadjah Mada, Yogyakarta, PhD program from Okayama University, Japan, and currently he is a Chief of Oral Radiology Department and a Chief of Dental Education Unit of Faculty of Dentistry, Hasanuddin University. He has many publications and articles according to his expertise. For moderator, the floor is yours.
Thank you very much, Dr. Yaya. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and good afternoon. We will continue the fourth session of ICoBTD 2021. The presenter or the speaker is Dr. Salim Al-Kabi from United Arab Emirates from Abu Dhabi. And the topic is about the impact of research on the future of dental education. Firstly, we would like to say thank you very much for Dr. Salim. Welcome to our conference. And we realize that now in Abu Dhabi, maybe it's very early day, maybe 3 a.m. So we really appreciate it because your willingness to join with our conference, and it is a big honor for us. And we're waiting for your presentation about the impact of research on the future. And we realize that in dental education, research is very important because with research we can improve the quality of dental education. And hopefully the participant also will follow the presentation, and you can ask Dr. Salim using chat room, and later when the presentation over, Dr. Salim will answer and give more explanation related to your questions. And now we can continue with Dr. Salim brief curriculum vitae.
Assalamu alaikum. First of all, thank you guys for having me here with you today, and really I appreciate also this thing. Actually, I am in Amsterdam, and the time here is exactly like 4 a.m. It is a bit different, to be honest, to wake up in this time, but it's okay. There are two things. The first thing, I think the title has been changed a little bit. It is about the research, but we moved it to a bit more clinical cases. So it's going to be like about the TMJ replacement.
Never mind.
If you don't mind, if you can, because I cannot share the slide, so I think you have to put me as a host in order to put the screen. Yeah, now it's okay.
Okay, please wait a moment. Okay.
Yeah. Today I'm going to talk about the temporomandibular joint replacement and the digital planning. This is our outline for today. We're going to speak about alloplastic TMJ replacement, and then we're going to see a couple of the clinical outcome from that. And I'm going to speak also about the design and material failure and the clinical cases on TMJ replacement. We're going to see also about the surgeon and related failure. What are the things that the surgeon could be mistaken on the surgery? And we're going to talk about the system, limitation related failure, and some of the research in general, past, present, and future. Before we go further, it's really important to mention here about the surgeon. Sir John Journey is an orthopedic surgeon, and he is from UK, and he is considered as a father of orthopedic surgery. So the hip replacement in general, and the temporomandibular joint replacement, or the joint replacement has been there since long time, from 1960 and 1950. What are the etiology in general about the TMJ problems? So before we go further with the surgery, we need to know what are the etiology. First, we have a trauma. Patient, for example, comes from car accidents or from a fight. We have an infection. Any infection can affect the TMJ in general, and some rarely caused by a systemic disease. And usually it comes from rheumatoid arthritis or ankylosis. And you can see here in the picture, the CT scan, you can see here, the ankylosis happening in the TMJ. What are the symptoms? So if a patient comes to our clinic or the hospital, complaining from what in order to do any kind of the TMJ surgery? So usually the patient comes with a TMJ pain, and this is the most popular symptoms. Secondly, some of patients also associated with the ear pain. So it's not only pain in the TMJ, but also associated with the ear pain. You can see in this picture, a clinical picture, we have a deviation of the mandible. So sometimes if we have ankylosis on one side, especially for example this side, so the patient will not be able to open his mouth. And you could see also the deviation. So we have a limitation mouth opening, and we have a deviation as well in the mandible. And definitely most of those patients, they have a continuous headache. There are a couple of treatments, especially we are talking, as I said from beginning, we're going to speak about the surgical intervention. So usually we have three kind of a treatment. The first one is the gap arthroplasty. And the gap arthroplasty is similar to this in this picture. So we only remove the condyle and we keep a space. And the idea behind this is to reduce the rate of free ankylosis by increasing the distance. So we keep the areas empty, then hoping that the ankylosis wouldn't happen again. The second surgical treatment, after we remove the condyle, we try to put something, and that's called interpositional arthroplasty. And what kind of material usually we place? It's autologous things. So like temporalis fascia, we can put temporalis muscles as well, or a dermis, fat, or ear cartilage. So sometimes we use like ear cartilage from here, and we put it in the condyle, or we, at the same surgical site, we use a temporalis and put it on the condylar area. And we get, the most importantly, now something called a reconstruction joint. So nowadays, the most of the surgeons, they try to do a reconstruction. And the reconstruction used to be with the autologous graft. So usually we get a graft from the rib, or from the hip, or from the fibula. But nowadays, they're trying to do something else on last 10 or 15 years. So they're trying to get an alloplastic joint instead of the autologous graft. And we're gonna know exactly what is the advantages and disadvantages of that a bit sooner. So what are the goal of the TMJ replacement? In general, if patient, as we mentioned, has a pain, we need to improve the function. If he has a limitation in mouth opening, we need to improve his function. We need the patient that he able to open his mouth. If the patient has pain, we need to reduce his suffering. We need to contain excessive treatment. So we don't need the patient that comes every time with a different treatment. We need also to contain the further cost. It means further surgeries, further cost, and prevent any further morbidity. And the important things here, we should not promise the patient that the pain will completely gone, or we can delete it completely, because that is almost impossible with a TMJ surgery or TMJ pain. As we know, a TMJ is a really complicated structure. So most of patients, they could reduce from the pain, they get really improvement, but not all of them, they get completely healed. This is the alloplastic joint replacement. So we have multiple structure, and sooner also we're going to talk about that. But what are, in general, what are the advantages and disadvantages of such implant? So first, it is available. So it can be ordered at any time. There is no donor site, as I said. Usually, it used to be that we used a hip graft or rib graft or fibula, but in this one, we don't need to get another graft. So we don't need another donor site. It conforms to any given anatomy. The manufacturer and the company, they can design the implant in any shape that we would like. And it's not susceptible to any foreign body or giant cells or systematic disease. For example, if patient have, let's say, rheumatoid arthritis, and the inflammation comes on this structure, so no way that can affect the titanium and cause them to degenerate. So it is well fixed and stable. The physiotherapy, we know that from orthopedic, we can have the physiotherapy exactly after 24 hours. And as we know from orthopedic as well, that early function is early healing. But these are the advantages. What are the disadvantages from the alloplastic joint replacement? First of all, as we know, it's a cost because it's really high technology. So definitely we expect that it's going to be a bit expensive. The other thing, it is an alloplastic material, so it could be susceptible to material hypersensitivity. If patients have, for example, allergy from titanium or some other materials, so this could be a disadvantage. And this is our main thing, the wear out. The wear out, we're going to speak about it a bit later as well. So the wear out is the most important thing with this kind of implant. And the last thing is the only skeletal mature patients. So this kind of implant, we use it only with the skeletal, I mean, above 18 or above 16 with the gears. It's mostly like a dental implant. I put here a question mark. Can we use them in less than that or not? We're going to see also soon in the future. What are the indications? So what are the indications to do a TMJ replacement? Of course, if we have an inflammatory TMJ problem, like arthritis, low osteoarthritis, or high rheumatoid arthritis, patient comes with a fibrous or bony ankylosis. You could see here the TMJ is completely enclosed, and actually this is bilateral case, this and that. You can see also from here, it's completely enclosed with a long coronoid process. Failed autologous graft. For example, if this patient underwent an autologous graft like a rib graft and then the graft got failed, so it's not wise to do another autologous graft. So I think it's better to do with the alloplastic graft. Failed alloplastic devices. So if it is, we have two types of devices, and if one of them failed, it's better to go to another one. Patient comes with loss of vertical dimension. So patient comes with the loss of vertical height. And usually it happens with a trauma, resorption, some kind of pathological lesions, or any other developmental abnormalities. Is there any contraindication? Definitely yes. Are those contraindications are permanent or relative? We usually consider them like a temporary or relative contraindication. And similar like a systemic disease. Some patient like uncontrolled hypertension, uncontrolled, for example, diabetes, uncontrolled any other systematic disease, which is not being able to put him under GA, general anesthesia, to proceed with the surgery. So unless the patient is controlled, then we can proceed with the surgery. Psychosis. Psychosis is really important things. What do we mean by the psychosis? Is the patient, for example, you give him and you treat him in a good way, and you believe that as a surgeon that the treatment is successful, but the patient is not realizing that, and he thinks that it's completely wrong. So we need to know that the patient is really psychosis or not. The third one, contra or relative contraindication, is the uncontrolled parafunctional habits, like what we see here in the picture. Patient has a severe paroxysm, clenching, and as we said, as much we have function on the plastic implant, the chances of the wear out and the part of that implant could goes out. We could have also local infections. For example, ear infections, parotid infection closer from the side, any local infection close and near from the surgical side. It's really important that don't let us to do the surgery at the same time, so we could defer it for a while. Documented material hypersensitivity. If patient have hypersensitivity from titanium, from chrome cobalt, or for example from ultra high molecular polyethylene things, because those are the materials used on a TMJ replacement. And the age, is the age a contraindication? Yes or no? Still, to be honest, not 100% being answered. And the reason why is that this is an article done in 2020 by Kaiser, and they studied that the alloplastic total joint replacement of the mandible, of course, in skeletal immature patients, and that was a pilot study. They used 24 custom patients with a specific TMJ and with the different implant brands. And those 24 custom patients, they used it in 14 patients. And as we said, there were 8 male and 6 female. The age difference were 7 to 17 with a range of 14 years old. And they came up with the conclusion that all surgery reported an improvement in maximum incisal opening. It means that all the surgery with those immature patients, they got a really good mouth opening. And the most importantly, it is they recommend that it is a useful modality in selected cases. So it's not generalized, it can be used with all immature patients. So for specific cases, and that's definitely, it can be decided by the surgeon, it might be a good option even for immature patients. This is another systematic review just to check the overall outcome of the TMJ replacement joint. Here we have the study done by Johnson in 2016, and they studied more than 312 patients. And you could see here we have a TMJ concept. This is one of the brand on TMJ replacement. The other good brand is Biomed, and the third one for the Nexus prosthesis. And they've done quite a lot of patients. So 1,048 over here, and here 505, and here is 196. And let's see the conclusion from that. Here, the Biomed prosthesis appear to have a greater increase in maximum incisal opening in compared to TMJ concept and the other. And in general, they concluded the prostheses are similar. It means that all of them, they give a good outcome and similar outcome. And this is what we need at the end. So regardless with a different kind of company, are the TMJ replacements is good or not? And with this conclusion, out of all of these patients, I think it's an indication that's a good optional for the surgical treatment. This is another systematic review, also comparing different kind of follow-up about TMJ and joint replacement. And they've done a meta-analysis to evaluate the effectiveness of different TMJ replacement with a different device. And also the result was the analysis showed no relevant difference in treatment outcome. It means that regardless the TMJ companies or brand, still they're giving a good outcome. In general, the TMJ replacement or the joint itself, we have two kind of TMJ replacement. We have something called as a stock replacement or custom replacement. Maybe from the name we can realize the difference. The stock, it means that it is fixed shape, we cannot change it. So it comes with a shape, for example, small, medium, and large. And we cannot do any modification on that. So it's a ready-made. This is what we mean by stock. And the other part is the custom TMJ device. Custom, it means that we customize this design, this implant for this patient. So if we do a custom TMJ for patient A, it cannot be used for a patient B. So only customized for this patient. I will not go through all of that, but at least I'll go with the most important things. So the stock device, as we say, it must make to fit. So we say that we have small, medium, large, but could be some patient has between small and medium, and we don't have that one. So we must make that device to fit. So I do whatever I can to make this device fit for this patient and fit for the surgery. So if I don't have a good fit, then I have to have a longer surgical time because I have to do some modification. And what kind of this modification? I have to do, bone must be removed and interferences. Otherwise, the device will not be fixed stable in the position. So if it doesn't fit stable, it means that difficult to gain the primary stability. So the device, it doesn't fit 100%. And if it doesn't fit 100%, it means that it could potentially affected by micromotion. So later on, we could end up with a failure. This story is completely opposite with a custom TMJ device. The TMJ device made to fit. What do I mean by that? It means that we already do our planning. We already done the CT scan. And so we designed that device exactly to the fossa or to the space to that patient. So it's made to fit exactly the surgical site. Shorter surgical time. So I don't have interferences. So I'm sure that this device, it will go directly, smoothly to the place. So definitely I'll be having shorter surgical time. No bone removal or in the interferences, because already it has overcome by the design. And even if there is a bone removal, it will be mentioned directly. So it will be like, okay, Dr. X, you have to make this this kind of bone removal in this area. So you know before ahead where to have to remove bone, you know exactly if you don't need to remove a bone area before the surgery. Definitely, we will be getting a primary stability. And of course, the micromotion, it will be none or very limited. And of course, you know, different kind of fossa, we're going to speak about them later. Now, From this systematic review that we've seen it just right before, we could come with a result and conclusion. So, of course, about the stock and the custom device. The good things first, both systems achieved significant increase in maximum incisal opening. So this is objective number one. It has been accomplished by both of the systems. So both of them, it can help with the maximum mouth opening. Both systems decreased in visual analog scale. This is a scale where to measure the pain. And both of them, they can help also in dietary scale. On a conclusion, we could know that, or we could see that the custom in general TMJ replacement device were more chosen in case with degenerative joint. And why is that? Because the degenerative joint are not really easy to reshape. So it's preferred to do a digital planning to have a specific shape for that surgery. And definitely, as we've mentioned, the custom TMJ replacement provide a significant operative advantage over stock device. So we have shorter time and better outcome. Now we'll see in general how many companies they're providing the TMJ replacement worldwide. We have 18 countries. We have 38 devices in general. 9 of those are stock device and 29 are custom device. So from this table only, we could see that most of the companies and the brands and manufacturer, they're moving to the custom devices. And it could be a sign where I think it's preferable than the stock device. This is another table showing also the same, the countries and the manufacturer. But here we'll start a bit about the component of the TMJ replacement. Generally, we have the fossa component, condylar component, and ramus component. The fossa component, usually the material, if you can see from here, the material used is ultra-high molecular polyethylene. And this material has been used for a long time in orthopedic, for decades. The condylar materials, you can see we have multiple, but most of it is a chrome cobalt. And the ramus components is the titanium, is the same like a dental implant material. Let's see the shape of that designs. These are different kind of shapes with a different kind of companies, of course. But most of those devices are alike, so they are similar to each other. We have fossa component, condylar component, and ramus component. Fossa component, condylar component, ramus component, and similar to every one of them. This is another also different kind of companies. And you could see that most of them are the same. Fossa, condyle, and ramus. Fossa, condyle, and ramus. Let's talk about the classification. So what are the classification of the failure of the alloplastic? Of course, we've mentioned that the good things about the alloplastic, the advantages, but also there are classification of failure. And we need to know that before ahead. So first we have a failure of concept. We have failure of implantation technique and limitation technology. What do we mean by failure of the concept? Failure of the concept like what they've done over here. In a couple of years, or mainly it's like 15 years ago or 20 years ago, they used to put, for example, if patients have a pain in TMJ, they used to remove the disc and they put a material in between. And that material used to be Proplast or silicone elastomer. And that's completely a failure idea, because whatever you put on there, those material cannot stand with the function during the load. When you start, because when you start eating, when you start, especially with those patients with the parafunctional habits, so these materials cannot stand with the load and under function, and definitely when it start to wear out, it's going to end up with the fibrosis and infection. Failure of the concept. At the beginning, they used to do something called hemiarthroplasty. Hemiarthroplasty means that they do one side of the condylar joint, and they didn't do the other side. And in these devices, it used to be the fossa was metal, and they leave the condyle. So what do you think? This is a metal, it's a dead element, and this is a living condyle. So definitely the metal will win, and the condyle will resorb. And you can see over here, say they put only the fossa element without a condylar element. And vice versa. Some of them, they start to do a condylar element without a fossa. And this metal was hitting directly to the cranial base. And that was a completely wrong idea. Other kind of failure, we have failure again in the concept. We have very thin condylar neck, ending up with a fracture on the neck. We have very thin ramus component. We end up with a fracture in the ramus, so they couldn't stand with the load. And here is one of the bad idea. This is they were using polymethyl methacrylate, and it is a purely denture materials. You see, and this is the area where they were thinking that this material will remodel, and what they didn't think of, when these materials will wear out, where it's gonna go? So it's gonna stay in the condylar joint. It's gonna end up with a fibrosis, and end up with the infection. Let's see if what do we mean by wear out? What could be the toxicity happen to the patients? In general, we have two kinds of toxicity. We have local toxicity, and we have systematic toxicity. As I mentioned at the beginning, that the cells of the body, it cannot attack the metal and the plastic, right? But the problem with the metal and plastic, the wear out part. So the part of that implant, if it's going to wear out and it causes small particles, what it's going to cause? One, it could be accumulate and cause a pseudotumor. It's like a fibrosis, a fibrous tissue collection. Still here, we don't have much problem. But our problem, if these kind of ions and materials goes exactly to the bloodstream, and then we'll be having the problems. One, if it's affected, it could be affect the kidney. We end up with the renal toxicity. Those ions, if it comes and deposit in the brain, we could end up with a neurotoxicity. If these ions end up with the cardiac or heart, we end up with a cardio toxicity. And the last one could be also precipitated in liver, and we end up with a hepatic toxicity. But this is mostly on orthopedic treatment. Do we have anything in maxillofacial? Yes, we do have, but after these couple of slides. So this is what we meant. This is a stock device, a failure stock device. We could see the loosening of the screws, and we could see the precipitation, deposition of the ions on the tissues. So it uses here up to here, still it's a fibrous tissue with some deposition. And if we remove this device, we could see the metallosis. You see the colored part of the bone. And this is what we meant by the wear out. Now, as I told you just now, do we have any serum metal levels in maxillofacial? the study was done by Professor Mercury, and they've done 4 things, or 4 different groups. Let's see them here. So the guys, they collected 4 groups, sorry. The first group was a control, and second group, they see the orthognathic surgery plates and screws. The third group is the TMJ replacement, and the fourth group is a dental implant. So the first group, they had nothing. So no implant, no plates, no chrome cobalt, no nickel. The orthognathic, of course, the orthognathic, we use screws and plates. So it comes from the titanium. A TMJ replacement, as we mentioned earlier, we have a titanium and chrome cobalt, and dental implant, as all of you know, that is made from the titanium. We will concentrate about the TMJ and the dental implant. So what do we mean by this now? If the wear out ions is 0.7 and less, is still considered as a normal level in the body. And we could see over here, all the control group, the one they don't have any kind of implant in their body, their serum level is below 0.5, it's even 0.3. And if we come to the TMJ replacement, still it's 0.7, 0.8, 0.9, still within the range. What is our problem if the level of the serum comes to the 2 and above? So we could see that actually in dental implant, the level of the titanium is really high. And this is a really indication that we have to do more study and wear out of the dental implant. And that is, it could be justified because of the load of the function during mastication, in compare definitely with the TMJ. So we have wear out and the ions in the serum from dental implant more than the TMJ. We have a limitation also in technology. So some of those devices are not really fit to and stable. Some of those devices are having micromotion under function, so they are not fit 100% to the bone. Some of those devices they got loosening, so the screws are not really fixed, and technology from technical part are not really stable, and definitely that end up with a failure. We can see that in a picture now. You could see that this is a stock device. And how do I know this? A stock device usually doesn't come with a posterior stop. So there is no stopper here. And that is really important in compared to this. You see, this is a custom device, and this is the stopper. If you see here, there is no stopper. And if we don't have stopper, this condyle is almost in the ear. So this is one of the failure of the technology. The second things we have is a surgeon problems. For example, failure on the fixation, failure in misunderstanding in biomechanics, failure on positioning the condyle. And we can see it right now. This is a bilateral case. Although the patient is in occlusion, but you can see that this one is not leveling with the other one. So as if the surgeon done nothing. So he has to go again to the OR and fix those TMJ in the proper position. This is another case. In relaxed position, you can see that the patient is not in occlusion, and the condyle is still touching on this side, but is not touching on the other side. And actually it's not leveling correctly. And the patient, when he's biting, this is touching and this is not. So still the surgeon has to correct the other side. This is another case, a stock device. The fixing is good from this side, but if we see from this side, this is the condylar fossa, and this is the ramus. So the ramus is 2 away medially from the condylar fossa. And, you know, because those are stock device, it's not meant to the patient, this patient. Let's see another implantation error. We have the fossa component are not fixed completely to the cranial base. So we have a space over here. And if we have space, as we explained earlier, that end up with a micromotion failure. Same over here, that the surgeon didn't remove enough bone because these are stock devices. So he didn't remove enough bone over here. End up with a space, end up with micromotions, and definitely a failure. The last screw is too long. So it's going to affect on the medial trigoid muscles during the function. So patients will start talking or eating, definitely he can experience a pain. Let's see a clinical case exam planning of ours. This is a CT scan done for a patient with a left condyle. This is usually what we do for a planning. So we send a patient to the CT scan, we take a CT scan, we do full 3D reconstruction, and then we discuss that with the company. So this is our proposal of the resection of the condyle, the red part. So this is a resection planning. Then we have to propose the design. So we imagine that the resection has been done. When we start to fix our condylar component, and then we start to fix our ramus component. Definitely also we have to see the ID nerve because it's an important structure for us, as you know. And also we have to make sure that the patient in occlusion. Then we have to look at it in different direction. Is the condylar head, it is in the center of the fossa? Yes. Then we try to separate the implantation alone. So we see the condylar fossa and we see the mandibular component, which check it from different view. This is in the center, and we check it from down. This is in the center. These are the different kind of screws. You know, we have to put 1, 2, 3, 4, 5, 6, 7, some of them 8 screws. And the most important screw, this is a good information to know, is the top screw. This is the most important screw, the top one. Again, we're gonna check the fossa component. How many screws? Usually 4, sometimes 5, but usually 4 screws. And then also we check it on the zygoma. These are the zygoma. And it's really important to be fit exactly on the bone, as we mentioned earlier. Here, another check. We check also here and there. This is different kind of color. You see this, the green color, and this is the bone solid. So the green color usually represent the air cells where there is no bone on there. So here, when we do the planning, we have to make sure that our screws goes to the really intact bone. And we plan exactly also the length of the screws. You can see here, this is a shorter one because we have a less thickness of the bone. This is a longer one because we have a good thickness. So the screws also being planned. I can show you here a fast video of how we do the planning. We do normal CT scan. Then we see it from all direction. And this is a bilateral case. Then we take only the mint part. I don't want the whole skull. We did the resection, both sides, right and left. Then we check it again. Now, this is important to check also, as we mentioned, the ID nerve here. I check the ID nerve, the pathway of ID nerve, because I don't want to injure the ID nerve. And then we make sure that the patient inclusion. Then we start our proposal here. We put first the fossa component, then the mandibular or ramus component. We check also the other side. Fossa component, ramus component, these are the stopper. And these are the custom device, of course, because the stop the stock device usually doesn't come with the stopper. Now we try to take the mandible out. We check the fossa. Is it completely fit in the zygoma? We check the other side. We check the level between both of them. Now we check the ramus part. It doesn't matter which one is longer or shorter, because every patient is different from the other, or each side is different from the other side. Here we check also the ID nerve, and this is almost the final. So if we agree about that, then they start manufacturing the devices. We're going to go a bit about the surgical cases. These are the surgical approach. Usually we do two approaches, one in periauricular approach, and the other one retromandibular or submandibular approach. Of course, we have to be careful about the marginal nerve, and we have a couple of vital, a couple of vessels there, the facial, retromandibular. Then on the preauricular side, we approach the condyle. So this is in the front of the ear. And on this side also, it's an important structure. Definitely you know it, just to remind you of that. You know, this is the external carotid artery, and gives to the temporal temporal branch, and it goes from this side a maxillary artery. And the maxillary artery is really too close from the medial side of the condyle. So we have to be sure and careful when we do the resection on this side. And then we start our resection. It can be done with the normal handpiece, or personally I prefer the bezo surgery, BS surgery. We remove the condylar head after we resect that. Then we introduce our implant. So we start with the condylar fossa. We place it on the zygoma, like here. This is the zygoma. So we place it on the zygoma of the patient. And then the ramus component, we were coming from the retromandibular or submandibular approach. So this is from the periauricular approach, and the ramus component comes from the retromandibular or submandibular approach. So we introduce it inside, and until the condyle comes in the center of the fossa component. Here we go further. We check everything in place. We make sure that's completely stable, and then we close. Now, post-operatively, we take an OPT or sometimes a CT scan as well, just to check, is everything in place or not? And here, the post-operative picture, patient and occlusion, good mouth opening, and this is the swelling a bit from the surgery. I think, what are the things that we have to take it home as a message? Alloplastic TMJ is a perfect option for TMJ reconstruction. I think right now we have really to put this as an option of treatment, apart from the alloplastic, autologous graft. Custom TMJ replacement is favorable than the stock TMJ replacement, and we saw that the advantages of disadvantages from both of them. Digital planning is really highly advised for a complicated case, of course, over the stock device. And we had still an issue with the immature patient, with the growing patients. We need, I think, more study on that. Thank you, guys. I think I finished my lecture up to here.
Thank you, Dr. Salim, for your nice presentation. Please, for the participant, if you have a question, you can raise hand or type the question in chat room. You can write in the chat room. Okay, before there is a question. Before we forget to show Dr. Salim curriculum vitae, actually. So before we have to share screen about the curriculum vitae, but Dr. Salim directly to share a screen his presentation. Okay, please, if you have a question. Okay, there's a brief curriculum vitae of Dr. Salim. Anybody, if you have a question, please type, or you can directly raise hand, and the host will allow you to directly. Okay, please, Dr. Aching.
Yeah, hello, Dr. Salim. Assalamualaikum.
Waalaikumsalam. Hi, Doctor.
Yeah, thank you very much for the nice presentation. So I saw in your presentation you make a change for the condyle, mandibular condyle, right? But I couldn't see the articular disc. I mean the articular disc between the condyle and the fossa mandible. So if you need to replace the articular disc, so is there any material that you may use to replace the articular disc? That's I want to ask you. Thank you.
Thank you, Doctor. You know, in alloplastic TMJ replacement, usually we don't replace a disc. For that, we try to use two different kind of materials to smoothening the movement of the condyle. So we use the condylar head from chrome cobalt And the fossa is from ultra-high molecular polyethylene. So it's like a smooth semi-plastic material. And that is the reason that we make the things really smoothly between the condyle and the fossa. So in the replacement by alloplastic joint replacement, we don't replace a disc. I think I hope I answered your question.
Okay, so in that case, we do not to replace the articular disc, right?
Yeah, we don't.
Okay. But how about the movement of the mandible? Is it okay without the articular disc? I mean, the movement of the opening movement and then lateral movement. Is there? Yeah. Okay.
Definitely, it's not gonna be like a normal TMJ. For that, this kind of surgery, it's been done only for a complicated cases like complete ankylosis of the TMJ, continuous severe pain from systematic disease like arthritis on the TMJ. Yeah, for that, if you notice that we cannot promise the patient 100% guarantee that the pain will go completely away, and we cannot also promise the patient that they will be 100% like before. But it is 100% we can promise that there will be an improvement. But for how long, how much, we don't know, to be honest. Yeah, it's between 60–80%. It depends from and varies from one patient to another. It's like when we do an autologous graft, the same thing. We cannot promise a patient that if we take a rib graft and after resection of the condyle, we cannot promise a patient that this will be 100% okay. It's totally different from bone augmentation of dental implant. Even if we do a rib graft, the chances of resorption is there, the chances of infection is there, the chances of re-ankylosis is there. But with the alloplastic, at least less chance of infection, less chance, or we don't have chance of resorption. But the only problem we have is it's one of the main problem we have is the wear out materials.
Okay, thank you. I got the point. Thank you, Dr. Salim.
Okay, thank you, Dr. Aching, for your question, and thank you, Dr. Salim, for your answer. We have another question from Dr. Nur Hikmah. She asked that what is the limitation when we want to do alloplastic joint replacement?
It's not a limitation. I would say it is the contraindication or relative contraindication. We already mentioned that. So we have a contraindication. For example, patient with a heart disease, we cannot anesthetize him, or an active heart disease, and the anesthetist, for example, wouldn't accept to let him sleep under GA. This is a general problem, for example, general systemic disease. But related to us is more toward the local infections. So if patient comes with a current infection, we cannot proceed with the surgery, because otherwise, if you place a device, an infection, definitely you know that a post-operative infection will stay. So there are a limitation with the systematic and that related to the GA cases, and there are a local measurement, and mainly it's an infection. Other than this, I don't think so. There are a major problem. Of course, with the growing patients, definitely this is another issue. Like we have an ankylosis from couple of syndrome that started from early age, 4 or 5 years. We cannot use these devices on them, and for that, the study that I showed, it was from the age range was from 7 to 17. But still, also I think they start most of those patients above 12, because as you use this device in growing patients, you know that in advance that you're gonna replace it after a couple of years, because the mandible will be growing, the TMJ is not growing, then you need to replace it to the bigger one. So these are the couple of limitation or consideration, let's say, to keep it in mind.
Okay, thank you very much for your comprehensive explanation related to the limitation and the relative contraindication. And we have the other one question from Dr. Irfan. His question is, what is post-operation instruction to the patient? So the post-operation instruction to the patient.
The post-operative instruction, right?
Yes.
Usually, it's interesting actually. Post-operative patient doesn't feel really much. This is one thing. Although the surgery is really big, but what we notice that most of patients, they don't experience a severe pain, and this is really interesting thing. But the normal post-operative instruction, definitely there are a surgical site that they have to be cleaned from time to time. They have to use the topical antibiotic. They have to continue with their medicine for the first 5-7 days, and most importantly, they have to practice the physiotherapy. So they have to start using their mouth after 24 hours. So the first 1 day or 2 days, we let the patient to be in soft diets, but from the third and fourth and further, we let them to start eating normally. We have also, the cold bags. They could use it for, they could, some of patients, they really got relief by that. But apart from this, we don't have any specific measurements. So like a normal post-operative surgery, they use their medication, and most importantly for us, they start physiotherapy or eating directly after 24-48 hours.
Okay, thank you for your explanation. Maybe I will continue about Dr. Irfan question about the instruction post-operation. How long usually the patient can open and close their mouth normally after the surgery?
This is different from one patient to another, but we would say that usually patient open from out of 2/3 of their normal mouth opening, so above like 38-40 mm and above. And this is definitely, it's different from one patient to another because we don't have a standard mouth opening for everybody, but we could see that patients, because when we compare previous patients' mouth opening, they usually open less than, some of them completely closed, some of them 1 centimeter, 10 mm only. So our comparison between patient to same patient, we don't compare other patients with other patients. So we compare the same patients pre-operatively, and we see him post-operatively, how's the maximum mouth opening. And most of them, they got really improvement with at least 2/3 to from the previous mouth opening.
Oh, okay. So depend on the patient condition before operation.
Yeah, the patient himself. We don't compare other patients. So it's not right to compare ourselves like a normal people mouth opening with someone with ankylosis, right? So we have to compare himself before from himself after.
Okay. Okay, thank you very much for your interesting explanation and comprehensive related to some question of the participant. And I think our session for Dr. Salim is enough because there is no more question. So I please Dr. Yaya to take the lead of this meeting. Thank you. Thank you, Dr. Salim, for your time.
Thank you so much
We really appreciate it because it's very early morning.
Yeah,
yeah. Thank you very much. We really appreciate it.
You're welcome. Thank you so much. Really appreciate it too.
Okay. Ladies and gentlemen, distinguished participant, now we will going to announce 2 best question participant. To get 1 bottle each of them from Oxy Fresh Breath from PT OHW Indonesia. Maybe for Dr. Irfan or Dr. Salim, you can choose the best question participant, please.
Please, Dr. Salim can choose Dr. Aching, Dr. Nur Hikmah, or Dr. Irfan.
I think the one with the desk, the first question.
Okay, Dr. Aching. And then the second is Dr. Nur Hikmah. She asked about the limitation, and Dr. Irfan asked about the post-operative instruction.
Yeah, maybe a limitation.
Okay, limitation. Okay, Dr. Nur Hikmah.
Okay, thank you for Dr. Salim and congratulations for Dr. Aching and Dr. Nur Hikmah. Please contact our contact person after this event today. After this event end today. And ladies and gentlemen, that's all our fourth session. And thank you for Dr. Irfan for your kind leading the session. So now we are going to certificate submitting for our speaker and our moderator today that will be delivered by the head of cooperation unit of Faculty of Dental Medicine, Universitas Brawijaya, to Mrs. Dia Nawang Palupi, Dr. Gigi MKes. Please, the floor is yours.
Thank you. Certificate. This is the certificate for Dr. Salim Al-Kabi.
Thank you so much, Doctor.
You're welcome. So next, the certificate for Dr. Irfan Sukianto, Dr. Kiki M. Med at PhD.
Thank you, Dr. Dia, for your kindness. Thank you.
You're welcome, Dr. Irfan.
Okay, thank you very much for Dr. Dia, Dr. Irfan as the moderator, and also the speaker, Dr. Salim Al-Kabi, for the great presentation and discussion about the impact of research of the future of the dental education. The session was really inspire our knowledge. Thank you, Dr. Salim, Dr. Irfan, and Dr. Dia.
Thank you, Dr. Salim, for your time and for your nice presentation. Thank you
so much. Have a nice day.
Have a nice day.
Bye-bye.
Okay. Okay, ladies and gentlemen. Now, before we enter the closing ceremonial, let's take a break for 10 minutes. Thank you.
Fakultas Kedokteran Gigi Universitas Hasanuddin secara resmi didirikan berdasarkan keputusan Rektor Universitas Hasanuddin dan keputusan Menteri Pendidikan sejak tahun 1983. Saat ini, peminatan terhadap Fakultas Kedokteran Gigi Universitas Hasanuddin semakin meningkat dari tahun ke tahun melalui jalur reguler dan internasional, sejalan dengan program World Class University. Hingga saat ini, Fakultas Kedokteran Gigi Universitas Hasanuddin telah menghasilkan ribuan alumni yang telah tersebar di seluruh dunia demi meningkatkan ilmu dan keterampilan, mengabdikan diri kepada masyarakat, mulai dari kota hingga ke pelosok negeri. Program studi kedokteran gigi Universitas Hasanuddin telah terakreditasi A untuk tahap sarjana dan akreditasi B untuk tahap profesi berdasarkan pada keputusan LAM PTKes. Program studi ini ditunjang dengan sarana dan prasarana seperti e-library Fakultas Kedokteran Gigi Universitas Hasanuddin, 33 ruang tutorial, 3 ruang kelas internasional, serta 3 aula. Ruang laboratorium, USC Center, ruang CBT, ruang jurnal dan unit production house, ruang dental education unit, serta bekerja sama dengan Rumah Sakit Gigi dan Mulut Pendidikan dan Rumah Sakit Pendidikan Universitas Hasanuddin. Program studi sarjana kedokteran gigi dan program studi profesi kedokteran gigi memiliki visi sebagai pusat pengembangan ilmu pengetahuan, teknologi, dan riset kedokteran gigi yang bersaing di tingkat nasional dan internasional dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat dengan berbasis benua maritim. Misi yang diemban oleh program studi pendidikan dokter gigi, baik tahap sarjana maupun profesi, adalah meningkatkan mutu pembelajaran berbasis kompetensi dengan metode student-centered learning dan menyediakan lingkungan belajar berkualitas untuk pengembangan kapasitas pembelajaran yang inovatif dan proaktif. Menumbuh kembangkan ilmu pengetahuan, teknologi, seni dan riset dalam bidang kedokteran gigi. Menerapkan dan menyebarluaskan ilmu pengetahuan, teknologi dan seni kedokteran, serta tanggap terhadap perubahan dalam rangka meningkatkan derajat kesehatan gigi dan mulut masyarakat. Usaha tersebut dilaksanakan demi mewujudkan tujuan akademis, yaitu untuk menghasilkan dokter gigi yang berkualitas, profesional dan bertanggung jawab, membangun karakter peneliti bagi dosen dan mahasiswa, serta kerjasama keduanya dengan memberikan dukungan maksimal pada setiap keikutsertaannya pada kompetisi karya ilmiah, serta menerapkan dan menyebarluaskan ilmu pengetahuan kedokteran gigi untuk masyarakat.
Fakultas Kedokteran Gigi Universitas Hasanuddin terbentuk sejak tahun 1983. FKG Unhas dengan visi Pusat Pengembangan Insani, Ilmu Pengetahuan Teknologi, Seni dan Budaya yang unggul di bidang kedokteran gigi dengan berbasis benua maritim. Kami terus melakukan upaya pengembangan diri sehingga saat ini FKG Unhas mempunyai 9 program studi. Program studi tersebut adalah program studi sarjana kedokteran gigi, program studi profesi dokter gigi, program studi pendidikan dokter gigi spesialis prostodonsi, program studi pendidikan dokter gigi konservasi, program studi pendidikan dokter gigi spesialis periodonsi, program studi pendidikan dokter gigi spesialis bedah mulut dan maksilofasial, program studi pendidikan dokter gigi spesialis ortodonti, program studi pendidikan dokter gigi spesialis periodonsi, dan program studi program magister ilmu kedokteran gigi. FKG Unhas saat ini mempunyai dosen tetap sebanyak 88 orang yang terdiri dari 20 orang guru besar, 19 orang lektor kepala, 27 orang lektor, dan 22 orang sebagai asisten ahli. Untuk mendukung kegiatan proses pembelajaran, FKG Unhas mempunyai ruang-ruang kuliah yang memadai, ruang seperti ruang CSL, ruang praktikum, ruang OSCE maupun ruang CBT. FKG Unhas juga bekerja sama dengan 2 rumah sakit pendidikan. Yang pertama yaitu Rumah Sakit Gigi dan Mulut Pendidikan dan Rumah Sakit Pendidikan Universitas Hasanuddin yang telah terakreditasi paripurna dan sudah ditetapkan sebagai rumah sakit pendidikan sebagai tempat wahana pendidikan FKG Unhas.
Seiring dengan kemajuan ilmu pengetahuan dan teknologi, program pendidikan Dr. Gigi Universitas Hasanuddin terus mengembangkan diri serta menjawab segala tantangan dalam memenuhi kebutuhan sumber daya manusia di bidang kesehatan gigi dan mulut di Indonesia adalah melahirkan lulusan yang berkualitas secara profesional yang mampu memberikan kontribusi konkret demi tercapainya peningkatan mutu kesehatan gigi dan mulut masyarakat di Indonesia. Dan sesuai visi program pendidikan Dr. Gigi Fakultas Kedokteran Gigi Universitas Hasanuddin yang berstandar internasional menjadi pusat pengembangan ilmu pengetahuan, teknologi, dan riset kedokteran gigi yang mampu bersaing di tingkat nasional dan tingkat internasional dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat dengan berbasis benua maritim Indonesia. Untuk menghasilkan dokter gigi yang berkualitas, profesional, dan bertanggung jawab sesuai dengan insan cendekia berkarakter maritim, setiap tahunnya kami selalu berupaya melakukan pembenahan sistem pendidikan dengan mengimplementasikan standar kompetensi dokter gigi Indonesia ke dalam kurikulum yang komprehensif dan bermutu tinggi dengan luaran yang terukur.
Program studi pendidikan dokter gigi terdiri atas 2 tahapan, yakni tahapan akademik dan tahapan profesi. Tahapan profesi merupakan lanjutan dari tahapan akademik. Penerimaan mahasiswa profesi dilakukan pada tiap periode yudisium tahapan akademik. Aktivitas mahasiswa tahapan profesi diawali dengan orientasi penerimaan mahasiswa profesi selama 2 pekan. Selanjutnya, mahasiswa akan menjalani kegiatan tahapan profesi selama 4 semester pada 9 departemen, yakni 8 departemen berbasis klinik di rumah sakit gigi dan mulut dan 1 departemen berbasis masyarakat. Kompetensi yang harus dicapai oleh mahasiswa profesi sesuai dengan standar kompetensi dokter gigi Indonesia yang dijabarkan dalam kurikulum tahapan profesi dengan penerapannya mengusung program One Visit Departemen. Kegiatan pemberian klinik tahapan profesi dokter gigi didukung oleh kualitas rumah sakit gigi dan mulut pendidikan Unhas yang sangat memadai dan terakreditasi paripurna. Penjaminan mutu pada program pendidikan dokter gigi dilakukan secara berkala, meliputi proses monitoring dan evaluasi, yakni menilai proses pendidikan serta fasilitas yang tersedia oleh gugus penjaminan mutu yang dilakukan setiap semester. Mahasiswa yang telah menyelesaikan tahapan rangkaian kegiatan pendidikan akan mengikuti uji kompetensi mahasiswa program profesi dokter gigi.
Bergabung bersama Fakultas Kedokteran Gigi Universitas Hasanuddin, program studi pendidikan dokter gigi demi amal padu mengabdi. Fakultas Kedokteran Gigi Universitas Hasanuddin secara resmi didirikan berdasarkan keputusan Rektor Universitas Hasanuddin dan keputusan Menteri Pendidikan sejak tahun 1983. Saat ini, peminatan terhadap Fakultas Kedokteran Gigi Universitas Hasanuddin semakin meningkat dari tahun ke tahun melalui jalur reguler dan internasional, sejalan dengan program World Class University. Hingga saat ini, Fakultas Kedokteran Gigi Universitas Hasanuddin telah menghasilkan ribuan alumni yang telah tersebar di seluruh dunia demi meningkatkan ilmu dan keterampilan, mengabdikan diri kepada masyarakat, mulai dari kota hingga ke pelosok negeri. Program studi kedokteran gigi Universitas Hasanuddin telah terakreditasi A untuk tahap sarjana dan akreditasi B untuk tahap profesi berdasarkan pada keputusan LAM PTKes. Program studi ini ditunjang dengan sarana dan prasarana seperti e-library Fakultas Kedokteran Gigi Universitas Hasanuddin, 33 ruang tutorial, 3 ruang kelas internasional, serta 3 aula. Ruang laboratorium, USC Center, ruang CBT, ruang jurnal dan unit production house, ruang dental education unit, serta bekerja sama dengan Rumah Sakit Gigi dan Mulut Pendidikan dan Rumah Sakit Pendidikan Universitas Hasanuddin. Program studi sarjana kedokteran gigi dan program studi profesi kedokteran gigi memiliki visi sebagai pusat pengembangan ilmu pengetahuan, teknologi, dan riset kedokteran gigi yang bersaing di tingkat nasional dan internasional dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat dengan berbasis benua maritim. Misi yang diemban oleh program studi pendidikan dokter gigi, baik tahap sarjana maupun profesi, adalah meningkatkan mutu pembelajaran berbasis kompetensi dengan metode student-centered learning dan menyediakan lingkungan belajar berkualitas untuk pengembangan kapasitas pembelajaran yang inovatif dan proaktif. Menumbuh kembangkan ilmu pengetahuan, teknologi, seni dan riset dalam bidang kedokteran gigi. Menerapkan dan menyebarluaskan ilmu pengetahuan, teknologi dan seni kedokteran, serta tanggap terhadap perubahan dalam rangka meningkatkan derajat kesehatan gigi dan mulut masyarakat. Usaha tersebut dilaksanakan demi mewujudkan tujuan akademis, yaitu untuk menghasilkan dokter gigi yang berkualitas, profesional dan bertanggung jawab, membangun karakter peneliti bagi dosen dan mahasiswa, serta kerjasama keduanya dengan memberikan dukungan maksimal pada setiap keikutsertaannya pada kompetensi karya ilmiah, serta menerapkan dan menyebarluaskan ilmu pengetahuan kedokteran gigi untuk masyarakat.
Fakultas Kedokteran Gigi Universitas Hasanuddin terbentuk sejak tahun 1983. FKG Unhas dengan visi Pusat Pengembangan Insani, Ilmu Pengetahuan Teknologi, Seni dan Budaya yang unggul di bidang kedokteran gigi dengan berbasis benua maritim. Kami terus melakukan upaya pengembangan diri sehingga saat ini FKG Unhas mempunyai 9 program studi. Program studi tersebut adalah program studi sarjana kedokteran gigi, program studi profesi dokter gigi, program studi pendidikan dokter gigi spesialis prostodonsi, program studi pendidikan dokter gigi konservasi, program studi pendidikan dokter gigi spesialis periodonsi, program studi pendidikan dokter gigi spesialis bedah mulut dan maksilofasial, program studi pendidikan dokter gigi spesialis ortodonti, program studi pendidikan dokter gigi spesialis periodonsi, dan program studi program magister ilmu kedokteran gigi. FKG Unhas saat ini mempunyai dosen tetap sebanyak 88 orang yang terdiri dari 20 orang guru besar, 19 orang lektor kepala, 27 orang lektor, dan 22 orang sebagai asisten ahli. Untuk mendukung kegiatan proses pembelajaran, FKG Unhas mempunyai ruang-ruang kuliah yang memadai, seperti ruang CSL, ruang praktikum, ruang OSCE maupun ruang CBT. FKG Unhas juga bekerja sama dengan 2 rumah sakit pendidikan. Yang pertama yaitu Rumah Sakit Gigi dan Mulut Pendidikan dan Rumah Sakit Pendidikan Universitas Hasanuddin yang telah terakreditasi paripurna dan sudah ditetapkan sebagai rumah sakit pendidikan sebagai tempat wahana pendidikan FKG Unhas.
Seiring dengan kemajuan ilmu pengetahuan dan teknologi, program pendidikan Dr. Gigi Universitas Hasanuddin terus mengembangkan diri serta menjawab segala tantangan dalam memenuhi kebutuhan sumber daya manusia di bidang kesehatan gigi dan mulut di Indonesia adalah melahirkan lulusan yang berkualitas secara profesional yang mampu memberikan kontribusi konkret demi tercapainya peningkatan mutu kesehatan gigi dan mulut masyarakat di Indonesia. Dan sesuai visi program pendidikan dokter gigi Fakultas Kedokteran Gigi Universitas Hasanuddin yang berstandar internasional menjadi pusat pengembangan ilmu pengetahuan, teknologi, dan riset kedokteran gigi yang mampu bersaing di tingkat nasional dan tingkat internasional dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat dengan berbasis benua maritim Indonesia. Untuk menghasilkan dokter gigi yang berkualitas, profesional, dan bertanggung jawab sesuai dengan insan cendekia berkarakter maritim, setiap tahunnya kami selalu berupaya melakukan pembenahan sistem pendidikan dengan mengimplementasikan standar kompetensi dokter gigi Indonesia ke dalam kurikulum yang komprehensif dan bermutu tinggi dengan luaran yang terukur.
Program studi pendidikan dokter gigi terdiri atas 2 tahapan, yakni tahapan akademik dan tahapan profesi. Tahapan profesi merupakan lanjutan dari tahapan akademik. Penerimaan mahasiswa profesi dilakukan pada tiap periode yudisium tahapan akademik. Aktivitas mahasiswa tahapan profesi diawali dengan
Okay, ladies and gentlemen, this is our closing ceremonial. For the first, our student from Asmat, Papua will present traditional dance. So, please watch and enjoy the show.
Tes mic 1 2 dicoba. Tes mic 1 2 dicoba. Tes mic 1 2 tes mic. Tes 1 2 1 2 1 2 cek cek. C 1 2 dicoba. C 1 2 dicoba. Cek mic 1 2 dicoba.
Okay.
Okay, ladies and gentlemen, sorry for the technical issue. This is our closing ceremonial. For the first, our student from Asmat, Papua will present traditional dance. So please watch and enjoy the show. Okay, ladies and gentlemen, distinguished participants, now we come to the award announcement session that will be delivered by Scientific and Award Division for Acing Habibi Muda Dr. Gigi, PhD Specialist Prosthodonty. The floor is yours.
Yeah, thank you very much, Dr. Yaya. Assalamualaikum warahmatullahi wabarakatuh. Now we enter to the participation, the session of participants have been waiting for. But before the announcement, I would like to say the Honorable Dean, Vice Dean, and lecturer staff of Faculty of Dentistry, Hasanuddin University, the Honorable Dean, Vice Dean, and lecturer staff of Erlangga University, and then the Honorable Dean, Vice Dean, and lecturer staff of Faculty of Dentistry, University of Brawijaya. So, as a person in charge for the scientific award session, I would like to send a big thank you for everyone, for all participants who attend or who present a scientific article in our scientific session. So it helped to make this event have a big success. So the enthusiasm of the participant to participate in this activity, it's very good, and we have a lot of participants, not only from Indonesia. We have a participant from Hokkaido, Japan. We also have a participant from Universitas Pajajaran, Universitas Gadjah Mada, Universitas Brawijaya, and so on. And then, as I want to report that all the article are well and then well presented. It's also excellent. So the judges actually need more effort to decide who would be the winner for this scientific award. So now we will go to the scientific award announcement of the scientific award. So actually we have 5 categories of the scientific award: research, case report, literature review, 5-minute literature review, and the poster. And then we continue to the announcement. Assalamualaikum warahmatullahi wabarakatuh. So this is our support sponsor, Oxyfresh Dentalitis and Gracia Jaya Mulia. Now we come to the competition announcement. So ladies and gentlemen, so who will be the winner? So for the research category, literature review, case report, 5-minute literature review, and poster. For research category, so we have 3 judges. The first is Professor Dr. Iren Editroy Pasa, Dr. Gigi Master of Science, Dr. Gigi Eri Hendra Jubari MKes Specialist Prosthodonty Consultant, and Dr. Gigi Rafika Hasim, Master Biomedic. And the third winner goes to with the score 78 for the maximal score is 100. With the title Association of Begonial Weed with Age and Gender Determination using digital posterior-anterior radiograph from Rido Akhri Prianto, Ruri Ratna Satiningsi, Munahir Mujo Semedi. Congratulations to Rido and team. So you will have a certificate and also financial support for our scientific, for our organized committee. And then the second winner is with the score of 79.3 point. As I said, the 100 is the maximal point. Effectiveness of Gambir extract, Uncaria gambirops, on the growth of bacteria Staphylococcus aureus. It's from Amira, Dr. Gigi Hafsakatu, Dr. Gigi Rahata Yongki, and Professor Harun Ahmad. Congratulations for being second winner. So we will provide a certificate and also the financial support for organizing committee and sponsor. And then we come to the first winner. The first winner is with the score 83.5 with the title Effect of Activated Charcoal on Reduction of Enterococcus faecalis Colonies. It's coming to Raden Roro Sri and Gunawan Wibisono, Ira Anggar Kusuma from Diponegoro University. Congratulations for Raden Roro. So we give you a certificate and also the financial support from our sponsor and our organizing committee. Congratulations and thank you for being participate in our seminar. And then we goes to the next category.
Assalamualaikum warahmatullahi wabarakatuh.
Now, the next category is literature review. So this is our judges. It's me, Dr. Gigi Andi Siti Hajra Yusuf, MS, and Dr. Gigi Rifaat Nur Rahma, SP Pros. And then the third winner with the score total of 80.7 goes to with the title Have an Endodontic Emergency Situation in COVID-19 Pandemic. What should we do? A literature review. Belongs to Lestari Hardianti and Dr. Gigi Nur Hikmah from Hasanuddin University. Congratulations. We provide 707. We provide a financial support for the third winner and from our sponsor. Congratulations. And the second winner of the literature review category with the total point 84.2 points from the maximal is 100 is with the title The Current Approach of Guide Tissue Regeneration in Angular Osseous Defect in Stage 3 Periodontitis belongs to Dr. Gigi Rahmawati DP and Professor Hasanuddin Tahir. Congratulations for being the second winner of this category. So we provide the financial support and also a certificate. Congratulations to Dr. Rahmawati. And then the first winner, who would be the first winner with the total score 85 points with the title Neurosensory Disturbance After Bilateral Sagittal Split Osteotomy Using Physiosurgery, a Literature Review from Dr. Gigi Nisrina Suyosi, Professor Muhammad Ruslin from collaboration from Hokkaido and Hasanuddin University. Congratulations to the Dr. Nisrina. We provide a certificate as well as support financial for the first, the second, and the third winner. Congratulations, Dr. Nisrina. And then we move to the next category for the case report. So these are our judges. The first, Dr. Maria Tanumiharja, Dr. Gigi MDSC, Dr. Gigi Irfan Sugianto, Master of Medical Education PhD, and Dr. Gigi Erni Marlina, PhD, spesialis penyakit mulut. Now we move to the third winner with the total point 77.3 points. Goes to with the title Surgical Removal of Impacted Supernumerary Teeth in Mandibular Premolar Region, a serial case and review of the literature. Belongs to Dr. Gigi Henry Jaya, Dr. Gigi Yosi, Dr. Gigi Siti Hajra, and Dr. Gigi Andi Tajrin. So as the previous category, we provide financial support and also certificate for the winner. Congratulations, Dr. Henry Jaya. And the second winner for the case report with the total point 79.3 with the title Outdoor Activities Modification and Recurrent Intraoral Herpes in Elderly Patient, a case report, belongs to Adi Ahmad Yusuf and Wahyu Hidayat from Pajajaran University. Congratulations for being the second winner. Congratulations, Dr. Adi. Now we come to the first winner of case report category with the total point 91.3 with the title A Case of Salivary Duct Carcinoma Possible Arising from Pleomorphic Adenoma. It belongs to Dr. Gigi Dedi Ariwansa. Dr. Gigi Adiwansa, congratulations for being the first winner of case report category. We provide the financial support and also a certificate for you. So congratulations and thank you very much for attend and participate in our scientific meeting. Congratulations. The next category will be 5-minute literature review. 5-minute literature review. So in this category, we have 3 judges. The first judges, Dr. Gigi Israyani, spesialis penyakit mulut. Dr. Gigi Fadil Ulum, spesialis radiologi kedokteran gigi. And the last, Dr. Gigi Sakriani Sahrir, spesialis kedokteran gigi anak. Thank you very much for being judges. And then the third winner with the score 68.7 with the title, The Effect of Diabetes on Patient with Full Denture, belongs to Andi Muhammad Saki, SKG, and Professor Edi Mahmud. Congratulations for being the third winner. We provide financial support from our sponsor and organizing committee. Congratulations, Andi Saki. And then the second winner for the 5-minute literature review with the total point 70.5 with the title Effective Effort of Dental Radiography Procedure During the COVID-19 Pandemic, belongs to Ilmia Amalia, SKG, and Dr. Gigi Irfan Sugianto. Congratulations, Ilmia. We provide the financial support for you and the certificate. Congratulations for participate in this meeting, in this scientific event. And then the number one, the first winner of the 5-minute literature review with the total point 78.8 points with the title E-cigarettes versus conventional cigarette, misperception on oral health impact, belongs to Fatur Rijal and Dr. Gigi Andi Anggun, spesialis penyakit mulut. Congratulations, Fatur Rijal. As the previous, we provide financial and also the certificate for you. So congratulations. And then we move to the next category, poster category. In this category, we also have 3 judges to assess the article and also the presentation of each presenter. The first judges is Dr. Gigi Andi Anggun Mauliana Putri, Dr. Gigi spesialis penyakit mulut, Dr. Gigi Yosi Yowanita spesialis bedah mulut, Dr. Gigi Rika Damayanti MKes. In this category, we have the third winner with the total point is 82.6 points with the title Endodontic Reintervention for Overdenture Abutment Teeth, a case report, It belongs to Mutmainah Majaya, Dr. Gigi Mutmainah Majaya, and Dr. Gigi Nur Hikmah. Congratulations, Dr. Mutmainah Majaya, and also congratulations to the Dr. Gigi Nur Hikmah. Congratulations for being the third winner. And then we move to the second winner. With the total score 84.2. With the title, Portable Dental X-ray, Safety of Use, Radiation Protection Awareness, and Regulation in Indonesia. It belongs to Husni Fadila and Dr. Gigi Fadil Ulum Ar-Rahman, spesialis radiologi kedokteran gigi. Congratulations. We also provide the finance to support for the next event. To the Husni Fadila, congratulations, and Dr. Gigi Fadil Ulum. And then the first winner of poster category with the total point 92 points. With the title, The Profile of Hematological Parameters After Pulp Out Application on the Acute Toxicity Test of Wistar Rats. Congratulations to Musfira and Dr. Gigi Maria Tanumi Harja. Congratulations for being the first winner. Congratulations. We also provide the financial support for from the organizing committee and the sponsor. Congratulations for the first winner. Yeah, congratulations to all the winner. Thank you very much for participate in our our event, and thank you very much for the judges for the effort to make assessment, and also thank you very much for the supporting team in resident conservasi. Thank you very much for helping the organizing committee. Thank you very much. And then I return to the Dr. Yaya.
Okay, thank you for Dr. Aching. And now we are in the closing session for this webinar that will be delivered by Chairperson 6 ICoBTD, Christine Anastasia Rovani, Dr. Gigi, Spesialis Konservasi Gigi Konsultan. The floor is yours.
Thank you very much, Dr. Yaya. Assalamualaikum warahmatullahi wabarakatuh. Shalom and best regard to all of us. The Honorable Dean, Vice Dean, and all Director of Faculty of Dentistry, Hasanuddin University, the Honorable Dean, Vice Dean, and all Rector of Faculty of Dental Medicine, Universitas Airlangga, the Honorable Dean, Vice Dean, and all Rector of the of the Faculty of Dentistry, Universitas Brawijaya, the Honorable, the international speakers, distinguished participants, ladies and gentlemen, praise the Lord as we finally complete this event, and it gives me a great pleasure to be part of this international event. And I would like to take this opportunity to thank to all the international speakers as well as short lecture speakers who have already present and shared their knowledge and great experience. We expect that all the speakers are willing to participate in any other event that we hold. To all the judges who have participated in the scientific award, and congratulations for the winner. And to all sponsors who are involved in this event, Dentalitis, Oxyfresh, and Gracia Jaya Mulia Company. And to all the committee members, I present my great appreciation for the teamwork professionalism. And last but not least, to all the participants who gave a contribution and great attention to this event. We do expect that the next ICoBTD is able to be held offline. So stay healthy and God bless you all. See you on the next event. Thank you very much. Thank you very much, Dr. Yaya.
Thank you, Dr. Christine. And ladies and gentlemen, distinguished participants, now we come to the end of the webinar. Allow me, Yaya, Inaya, and all organizing committee to say thank you very much for your participating and attention in this webinar, and apologize if there is any mistaken in this event. Hopefully, we will see you again in another webinar. Thank you for your all kind attention. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon and keep healthy and sound. Thank you.
Assalamualaikum warahmatullahi wabarakatuh.
The Honorable Chancellor of Hasanuddin University, the Honorable Dean of Faculty of Dentistry Hasanuddin University, the Honorable Dean of Faculty of Dental Medicine of Universitas Airlangga, the Honorable Dean of Faculty of Dental Medicine of Universitas Brawijaya, the international speakers, distinguished participants, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh, and best regards to all of us. It is a great honor that we, Faculty of Dentistry Hasanuddin University, welcome you all to the 6th International Conference of Biophysical and Technology in Dentistry under the theme of Global Trend Transformation in Dental Practice and Research in collaboration with Universitas Airlangga and Universitas Brawijaya. Our gratitude and a warm welcome go to our plenary and featured speakers as well as the presenters, especially the international ones. As we are all aware, the global situation is still affected by COVID-19 pandemic. Thus, our aim is to advance the development of dental science and technology in line with global trend transformation. And we hope that this conference does just that. This conference will be held online for 3 days, and there will be 12 featured speakers from 8 countries presenting by Zoom meeting. And in addition to short lectures, by speakers from a number of universities, which will be broadcast on YouTube channel. In closing, we hope that this conference provides the opportunity to learn with and from each other, as well as networking and building a strong development in dental science and technology. Thank you for all for coming and